अच्छा. मीठ घातलेलंच ना नक्की?
सगळं.
ठीक आहे.
Supriya, you are mute.
I hope
It
you
can't
didn't
be. She
practice
can't
your
be.
voice on Ramesh by shouting at him.
She can't be. She's saying Supriya is.
Ujjwala's range is not there.
So we are live now.
Okay, great. Okay.
And I'm
Let's
starting
start.
the session.
Yeah.
Yes. So good evening to all respected faculty members and delegate members who are present over here. I am Nilesh Darji from Corona Remedies welcomes you all in this 194th edition of Happy Learning Masterclass webinar series in association with Raigad, Thane, Navi Mumbai, Palghar and Sindhudurg Nagari. The theme for today's webinar is amniotic fluid abnormalities, and the convener for today's webinar is Dr. Asha Jain. So let me introduce Madam. So Dr. Asha Jain Madam has a very vast 34 years of experience in the ops and gynec field. Currently, Madam is Director SMSA Hospital Raipur, Medical Director CPRS, which is an NGO, elected member of Chhattisgarh Medical Counseling, and Madam has also FOXY recognized ultrasound and colposcopy training centers. Madam's fields of interest are saving the uterus, fetal medicine, obs and gyne ultrasound, critical care, and preventive oncology and colposcopy. Madam is also ISCCP, IFCPC, IAR colposcopy trainer. So I welcome Dr. Asha Jain Madam. And as per the traditional course, we will start our webinar with a digital lamp lightning session. So we will. Thank you so much for your patience. Now I hand over the session to Dr. Asha Jain. Madam, Dr. Asha Jain Madam will take it further. So over to you, Madam.
Thank you so much, Nilesh. So, namaskar, all respected faculty, to this fourth edition of Happy Learning Masterclass. The director of this program is Dr. MC Patel, sir, somebody who's very well known to us. He will be introduced formally when his lecture comes on, but I would just like to say that sir is approachable. He is very reachable, very down to earth, very consistent, and he is going for President FOXY this year, requesting everyone to please vote for him. And now I invite Sir to give his formal welcome address. Welcome, sir.
Thank you, Asha. It gives me immense pleasure to welcome you all on 194th episode of Happy Learning Masterclass web series. And today's joining society, Raigad, Thane, Navi Mumbai, Palghar, and Sindhudurg Nagari. I welcome Dr. Rajnish Patel, good old friend, who has kindly consented to be guest for today's webinar to bless us. He is very busy, but even though he has joined this webinar to bless us, it shows his love and affection to me. Welcome, Dr. Rajnish Bhai. I also welcome learned speaker, Dr. Swarupa Iyer. She is going to discuss very interesting topic, polyhydramnios. And to chair that very interesting session, I welcome Dr. Jyoti Bobe from Navi Mumbai, Dr. Sonali Sete from Raigad, Dr. Rajendra Chavan sir from Palghar. One more important topic is going to taken by Dr. Bharti More, and she is going to talk about oligohydramnios. And to chair that interesting session, Dr. Rajendra Tiwari from Palghar, Dr. Sanjay from Sindhudurg Nagari, and Dr. Ujjwala from Thane. And third topic, I am going to cover a very interesting part, that is legal issues in amniotic fluid embolism. Of course, it is a very rare condition, but fatality is more than 50%. And usually these are the potential cases. That is why we have selected that very topic, and we are going to discuss true happened case with one of our Foxian friend, and we will discuss. And to chair that interesting session, here is with us Dr. Kiran Marathe, Dr. Vishwas Parulekar from Navi Mumbai, and Dr. Rahul Vani from Navi Mumbai. And very interesting panel, case-based scenario, to be moderated by Supriya Arwari and Dr. Sandhya Saran, both from Thane. They are going to moderate very interesting panel, case-based discussion. And to make this panel more interesting and vibrant, I welcome 7 learned panelists. Dr. Sarmita Birbole Madam from Sindhudurg Nagari, Dr. Rajesh Navalgund from Sindhudurg Nagari, Dr. Santosh Jaibai from Navi Mumbai, Dr. Alka Godbole Madam from Thane, Dr. Himani Sharma Madam from Navi Mumbai, Dr. Neha Bothra Madam from Navi Mumbai, and old good friend Dr. Shailendra Jadhav from Thane. I also welcome Dr. Asha Jain, who is convener in this series since long. She is from Raipur, past president of Raipur, and this year in Foxy election, she is contesting for post of Food, Drug and Surgical Medical Equipment Committee, Foxy, and she is very deserving candidate, hardworking lady. So I request all the society who have joined and all the president and secretary who are going to vote for her. As far as my election is concerned, it will be from 1st August to 10 August. And as far as Asha Madam's election is concerned, it will be from 16th August to 25th August. I also welcome 2 coordinator, Dr. Monica Umardan from Solapur and Dr. Rekha Rajendra Kumar, president of Bengaluru Society. Both are in this series since long, and we are working together as far as academic activity is concerned. So in era of COVID-19, when I started this series with 3 more friends, and at that point of time, my intention was to meet our Foxian friends on virtual ground to discuss focus topic and to discuss one medical legal aspect related to that very subject. And this series is continue, and I am happy to announce it is now more than 7,000 plus member family as far as Happy Learning Masterclass web series is concerned. And today we are going to discuss about amniotic fluid exclusively, oligohydramnios, polyhydramnios, and amniotic fluid abnormality and amniotic fluid embolism, as just I mentioned prior also. So I welcome all the president and secretary of joining society, that is Raigad, Palghar, Thane, Navi Mumbai, and Sindhudurg Nagari. I also welcome all the delegates who have joined this webinar, and without wasting much of your time, welcoming you all again, I hand over mic to Dr. Asha Jain.
Thank you, sir. Thank you so much for those kind words and appreciation. And now, may I have the CV of Patel, sir, our guest of honor?
Let's keep it short.
Sir, it is already very short. You were here in one more program once. So, sir is the past president of Thane Society, an obstetrician, gynecologist, and lab surgeon. He had double gold medal in MD from Nair Hospital, 34 years in private practice, associate honorary professor at Rajiv Gandhi Medical College and Chhatrapati Shivaji Maharaj Hospital, Kalwa, since more than 25 years, head of Unit 3. He is a recognized basic lab skills course instructor in RCOG, member MDR Committee Thane Municipal Corporation, visiting consultant Jupiter and Kaushalya Hospitals Thane, and peer reviewer for Journal of Surgical Simulation, JSS. He is also the recipient of Thane Gaurav Award, and he's always very kind enough to be with us whenever we call him. So welcome, sir. We would really love to have your words of blessings.
Thank you. As they say, am I audible?
Yes.
Yeah.
Yes. Yes, sir.
Yes,
Thank
sir.
you. Thank you for the kind introduction, Dr. Asha Jain, and thank you for calling me up to remind me as well, taking time out of your busy schedule. I'm delighted to be the guest of honor. Doubly so because my home society is involved in this webinar, and many of my neighboring societies are also involved. So thank you, MC Patel sir and his team, for giving me this honor. And as the MC Patel sir says, रात को 12 बजे भी फोन करेंगे तो हम काम करने को हाजिर हो जाएंगे. Not a problem at all.
Yes.
If any of you all have seen the brochure, it says 194th edition. And if you divide it by 52, it almost gives us 4 years of relentless hard work on the part of Dr. MC Patel sir in his pursuit of disseminating knowledge through happy learning. You have to remember that in the COVID times, he was not going to stand for Foxy presidency.
Yes.
So it has all started with the pursuit of dissemination of knowledge through the Zoom platform. And I wish him all the best and request all of you, as Dr. Asha Jain said, to make him the president in this upcoming election. So I would like to give a big round of applause for 4 years of relentless pursuit of happiness, of the Happy Learning series. Now I see that the topics today are very interesting. Oligohydramnios, polyhydramnios, each of them comes with their own problems. Polyhydramnios comes with congenital abnormalities, and later on maternal distress, and oligohydramnios comes with IUGR and the most dreaded intrauterine fetal death. And any of us faculties would be lying if we do not admit that at least once in our life, during our residency or in our private practice, we must have entered amniotic fluid embolism as a cause of death.
Yes.
And today I'm sure MC Patel sir, with his inimitable way of talking, embellished with a lot of cartoon-like figures, is going to teach us what not to do if you are going to write amniotic fluid embolism as a cause of death. And with the vibrant ladies from Thane Obstetric Gynec Societies, Swarupa, Ujjwala, Supriya, and I can't see Sandhya, but she must be there somewhere, I don't know. I'm sure it's going to be a very happy learning experience for everybody. I wish you all the best. And again, applaud MC Patel sir's efforts. Thank you so much.
Thank you, Dr. Rajneesh Bhai, for sparing time to bless us. Of course, you are always with us in any of our academic activity. So thank you. Thank you very much.
Thank you, sir. So today we have a really short inaugural, and with due permission, I would like to start the scientific session. So may I start the scientific
Oh
session?
yes, oh yes, oh yes.
So I would like to introduce the chairpersons of the first talk. So welcome Dr. Jyoti Bobe ma'am, who's the president of Navi Mumbai Obstetric Gynec Society. She's been practicing since 31 years in Navi Mumbai. She's a consultant at Anuja Nursing Home and IRC Airoli, Apollo Hospital CBD Belapur, and Kokilaben Dhirubhai Ambani Hospital, Koper, Khairani. Welcome, Jyoti ma'am. We have Dr. Sonali Shetye. She is practicing since the last 15 years, director at Molly Nursing Home, Raigad, secretary of Raigad Obstetric Gynec Society, ex-lecturer at JJ Hospital, and her special interests are high-risk obstetrics and infertility. Welcome, Dr. Sonali. Then we have Dr. Rajendra Chauhan, sir. He is chairman of Kanta Maternity Hospital, Palghar. He is the president of Palghar Obstetric Gynec Society. He's been awarded by MOGS, Foxy, Government of Maharashtra, does a lot of social work, practicing in a rural area, organized blood donation camp, more than 1,000 blood donation camps. And he's been doing laparoscopic tubercle ligation since 33 years in rural areas. His area of interest is high-risk pregnancy. Welcome, sir. Over to chairpersons to introduce our speaker. I would request one chairperson to introduce the speaker, the other to introduce the topic, and the third to conclude the session. So requesting for introduction of the speaker, Dr. Swarupa Iyer.
Good evening, everyone, and thank you so much, Dr. MC Patel, sir, and Asha Jain, madam. It's a pleasure to introduce Dr. Swarupa Iyer. Madam is consultant obstetrician and gynecologist and fertility specialist. She is into practice since last 28 years. She is medical legal advisor. Madam was a secretary of TOGS in 2022 and 23. She is member of Ethics and Medical Legal Committee of FOXY. She is peer reviewer of Journal of Obstetricians, Journal of OBGYN India. She is part of legal team, Apex Insurance, and she is consultant at Apollo Fertility, Bapat Nursing Home, Curie Hospital, Jupiter Hospital, as well as she is honorary laparoscopic surgeon at Kutumba Kalyan Kendra. Madam is dynamic speaker, and I think all of us will enjoy her lecture. Thank you so much, ma'am. Over to you.
Thank you, Dr. Jyoti, for such kind words. It is, you can call me Swarupa. We are more friends. So,
sure, ma'am. Thank you.
So thank you for the introduction, and with permission of Dr. MC Patel and Rajneesh Patel, to the power of 2, I'd like to start my talk. And congratulations to MC Patel, sir, for such wonderful series, which has been going on for 4 years. And sir, it was my privilege to be part of it. I think this is my 5th time that I am there on Happy Learning. So it was a very, very happy experience, and thank you for the opportunity to you and to your team, sir.
Thank you.
I'd like to share my screen. It's visible, right? Is it visible?
Yes.
Yes, ma'am.
Yes.
Okay. So polyhydramnios, as the name suggests, more lichen. Though it's all fluid, the topic is little dry. So I have kept some theme for my slides. That are going to be taking inspiration from Dr. Patel, Dr. MC Patel, sir. There are certain cartoons in my presentation where uterus will be talking to the fetus. I hope you all enjoy it. So more is not always merrier. Here, basically amniotic fluid is a balance between fetal swallowing of amniotic fluid and fetal production of fluid in form of fetal urine. So to give a perspective, till around 16 weeks of life, fetal kidneys are not functioning. So the fluid is actually formed by lung fluid, placental membranes, and certain amount of fluid is also secreted by fetal skin. So this occurs till the time fetal skin keratinization is complete, which gets completed at around 28 to 32 weeks. So till around 24 weeks, you can say the major chunk of the fluid is formed by these few things. And later on, the fetal kidneys take over in form of fetal urine. So fetal almost swallows around 500 to 1000 ml of fluid per day. It is said that complete amniotic fluid volume is circulated or rather recirculated almost every day. So any disturbance in this production or resorption of amniotic fluid will going to lead to polyhydramnios. So since we are clinicians first, though the diagnosis is clinching mainly by ultrasonography, clinically we should at least suspect mainly by fundal height, which is going to be always more than gestational age. Almost 3 to 4 centimeter difference. Like for example, patient comes to you at 28 weeks and you find her fundal height is 32 weeks. There is a clear-cut suspicion for polyhydramnios. In such cases, you may not be able to palpate fetal parts because the fluid overload is so much. If it is severe polyhydramnios, you may feel that patient's skin is tense and stretched, and even the uterine wall is tense. Now, coming to diagnosis with sonography, so how is it diagnosed? So it is a single deep vertical pocket of more than 8 or 9 centimeters. There is discrepancy. Some says it is 8, some 9, but more than 8 centimeters is polyhydramnios. Or you can have amniotic fluid index, where you can measure this fluid pockets in 4 quadrants. I'll be showing you in the next slide. If it is more than 25, the AFI more than 25, it is again polyhydramnios. Now, these two techniques, single deep vertical pocket and amniotic fluid index, do they have any significance or anyone will do? The answer is anyone will do. And in the people where some beginner is doing sonography, always better to stick to single deep vertical pocket because the chances of error are less. But here, word of caution, what things must not be done. First of all, the probe position should be right. It should be absolutely vertical to the surface of the skin. And there should not be undue pressure given to this. So this is the right position, this thing. And this is not the right position where it is slanting. Another thing, in the frame where you are measuring the pocket, it should be a clear pocket, the way it is shown here. So this is around 11 centimeter and this is polyhydramnios. Now, in this frame, you can see there are multiple fetal parts which are cutting the frame. Then this is not the right way of measuring a single deep vertical pocket because these two things, even the umbilical cord for that matter, is going to give you erroneous reading. So see to it that the frame in which you are measuring single deep vertical pocket should be clear of all the fetal parts and umbilical cord. With these few words on how to measure polyhydramnios, we'll go to the just a quick physiology of amniotic fluid. Why is it so necessary? It is considered as elixir of fetal life. So the main functions of amniotic fluid are, it creates physical space for fetal movements, which is necessary for the normal musculoskeletal development. So baby movements that baby actually does in utero are essential for the development of the musculature also of the baby. It also permits fetal swallowing, which is essential for the gut development, even the gut bacteria and the lung development. It protects against umbilical cord compression and acts as a shock absorber. We know in oligohydramnios, we are worried about this. It prevents adhesion of the fetus to the amniotic sac. It has bacteriostatic properties and maintains fetal temperature. During labor, it acts as a hydrostatic wedge, which helps in the cervical dilatation when the membranes are intact. And also during uterine contraction, amniotic fluid prevents the interference with placental circulation when membranes are not yet ruptured. So coming to causes now, which are the most important part of the whole discussion. So as I had said, if there is any problem with fetal swallowing or there is a problem with fetal urination, both are going to cause polyhydramnios. So less swallowing and increased urination. So what are the things which will lead to less swallowing? First of all, any obstruction in upper GI tract, namely esophageal atresia, duodenal atresia, or tracheoesophageal fistula. Now, certain neck swellings also can prevent fetal swallowing, like fetal hygroma. Before going further, I want to discuss this esophageal atresia and fistula because sometimes they can be really tricky. And since I want to highlight some practical points, many times esophageal atresia presents as absent stomach bubble, as it is seen in this slide. So absent stomach bubble is almost kind of a diagnostic of esophageal atresia. But mind you, the trick here is presence of stomach bubble does not rule out esophageal atresia. The reason is the gastric secretions itself can produce some amount of kind of bubble appearance, and it may show as a small bubble which can be missed as a normal stomach. Secondly, many times esophageal atresia is also associated with tracheoesophageal fistula. Almost in 80% of the cases. So whenever atresia is associated with fistula, the stomach bubble may still be present and the atresia and fistula may be missed. So I think medico-legally this part is very important. Secondly, when there is a duodenal atresia, you may get this double bubble sign because there is a constriction between duodenum and stomach, and the duodenum is also dilated and stomach is also dilated, and both will lead to polyhydramnios. Now, why I'm giving so much of a details? There are two things. First of all, when the stomach bubble is seen, it has not ruled out your upper GI obstruction. So when there is a scenario of polyhydramnios and you are not finding any anomaly, many times it is called as unexplained polyhydramnios or idiopathic polyhydramnios, we need to investigate further. It is better to do a second sonography through some expert. This will just save you in future so that you know that you have done everything possible in your capacity to rule out anomalies. Now, certain CNS causes which are going to cause polyhydramnios are anencephaly, meningomyelocele, because the open meninges are going to they form a lot of exudate and the volume of the amniotic fluid increases. Twin to twin transfusion, one twin becomes hydrops and becomes and there is a polyhydramnios. Then when there is a Rh isoimmunization and severe fetal anemia, that is going to cause polyhydramnios. And of course, we all know diabetes mellitus in the mother or gestational diabetes is going to cause polyhydramnios. Now, in the next slide, you will see, though I have enumerated so many causes, almost 60% of the whole polyhydramnios is idiopathic, where we really can't pinpoint the reason. But again, a word of caution over here. There are at least 3 studies available on the net where it says in all those unexplained polyhydramnios, unfortunately, almost 25% of the times there was some fetal anomalies which was missed at the time of antenatal screening. So even if there is slight doubt, and though anomaly scan is normal, as I said, a repeat sonography after with some expert will always help. So as I said, there was I'm going to present 2-3 cartoons where there is a dialogue between uterus and baby. So here uterus is saying this is the truckload of the weight that I'm carrying, and it tells baby that it's your fault. So swallow more fluid or pee less. Otherwise, it is very difficult to carry you, and the best way is to throw you out. So the conditions that I enumerated, just giving in picture form so that we obviously have a better pictorial memory. So it will help us to remember anencephaly, esophageal atresia, meningomyelocele, cleft lip, cleft palate, which prevents better swallowing, hydrocephalus, and aneuploidy. Aneuploidy, I'm just going to talk a little further in detail. This is a very interesting cause of polyhydramnios. As I said, there is anything which prevents swallowing, any neck swelling. This was a very rare case where there were 6 loops of nuchal cord around the baby's neck. And obviously, it was very difficult for the baby to swallow. And this led to polyhydramnios. But it was diagnosed very well because these 6 loops were very obvious. It was almost it was strangulating the baby. So again, coming to unexplained hydramnios and neonatal outcome, as I said, in spite of normal antenatal care, it might be that 25% of the neonatal newborns may still be having some anomaly. And not all anomalies are picked up in the first sonography. So better to have a follow-up scan and second opinion if possible. Now, this is like to complete the academic list, I want to discuss about what is called as Bartter syndrome. Though very, very rare, sometimes we may get stumped in case of unexplained polyhydramnios. This is a group of disorder in the baby which causes hypokalemic metabolic alkalosis, hypercalciuria, and salt wasting. Basically, the problem is in the ascending loop of Henle, where salts like sodium and chlorides are not absorbed and they are thrown in the baby's urine. And that's why baby has a what is called as osmotic polyuresis. This is an autosomal recessive disorder, so it is transmitted if both the partners are positive, which is again a rare condition. So these babies actually they are delivered properly. They live at least till the age of adulthood, but need a lifelong treatment. So if it is if we miss this, it is going to be a very sad scenario. These babies crave for salt, they crave for chips, they are always dehydrated, they need a lot of water. And it's a very lifelong, tricky, tedious treatment to these patients. So specifically male fetus, onset of polyhydramnios between 24 to 32 weeks. There is a history of polyhydramnios in previous pregnancies. These patients should not be labeled as unexplained polyhydramniosis, but should be investigated with genetic studies in the amniotic fluid. Mind you, even esophageal fistula, atresia, many times they are associated with trisomy 21, that is Down syndrome, or sometimes even trisomy 18. So amniotic fluid genetic studies are at least they can be offered to the patient if there is a polyhydramnios and we are not able to find the reason. Of course, male fetus you won't be revealing to the patient, but the person doing sonography may know this is a male fetus and there is a polyhydramnios. That should raise a red flag. So what are the investigations? Of course, sonography, that is going to be the clincher for the diagnosis. ABO and RH typing to rule out RH isoimmunization. Glucose tolerance states to see the sugar status of the mother. And amniotic fluid studies for either alpha-fetoprotein or genetic studies. Now, there are some remote differential diagnoses just to complete the academic list for polyhydramnios. A large ovarian cyst can mimic polyhydramnios, and even the maternal ascites sometimes can be confusing to differentiate it from polyhydramnios, though it is very rare with such a advanced sonography techniques now. So what are the complications of polyhydramnios? Now, as this uterus is saying, can't handle so much of a fluid, expelling you sooner is better. So preterm labor. Fetus is almost floating in the water, can lead to fetal malpositions, umbilical cord prolapse. And since the uterus is stretched beyond limit, postpartum it is going to lead to atonic PPH. So to enumerate, during pregnancy, it can lead to preeclampsia, malpresentations, premature rupture of membranes, preterm labor, and accidental hemorrhage. During labor, early rupture of membrane, cord prolapse, and uterine inertia, leading to PPH again. So to go through the management quickly, I have already enumerated the investigations. So to tell in brief, there can be only two things. Either baby is normal, you have found any congenital anomaly, or baby is not normal. If baby is normal, we just need to investigate all these things, rule out the causes for polyhydramnios in mother, like diabetes, RH isoimmunization. And she just needs, even the mild polyhydramnios, they don't need so much of a treatment. So continue the pregnancy and they can be managed like any other routine obstetric case. If fetus is found with the abnormality, now if the anomalies that I have enumerated, most of them will need termination. So a termination can be offered to the patient and this pregnancy needs to be terminated. Now, if polyhydramnios is so severe that is going to cause maternal distress, then we need to treat it only if it is less than 37 weeks. then less than 37 weeks, one may consider amnio reduction. I'm going to talk about it in detail. And if it is more than 37 weeks, maturity is complete, we can do induction of the labor with stabilizing the fetal presenting part with oxytocin and then doing controlled artificial rupture of membranes. Here, controlled word is very important because the sudden rupture can again cause cord prolapse and we don't want that. Now, amnio reduction is, I feel, again, very theoretical. I have seen in very less number of patients it has been done. Society of Fetal Medicine gives it a grade C evidence. So indicated only in very severe polyhydramnios where your AFI is more than 35 centimeters. And again, these patients may need repeated amnio reduction. And again, mind you, where polyhydramnios is so severe to cause maternal tachypnea, respiratory distress, most of the time there are going to be some associated fetal anomalies which need to be ruled out. Role of indomethacin, again, mainly theoretical, used again in very severe polyhydramnios. Frankly, I have not used in my practice, but the book gives a dose of 25 milligram 4 times a day. But again, Society of Fetal Medicine gives it, it is a evidence grade 1B. Reason is, if used after 32 weeks, it can cause early closure of ductus arteriosus. It also leads to intraventricular hemorrhage. It increases, basically it reduces polyhydramnios by reducing fetal urination. So can lead to increased creatinine in baby. It can also lead to intraventricular hemorrhage. So the Society of Fetal Medicine clearly says the benefits are quite less compared to the risk. So risk outweighs the benefit, and this is not indicated in polyhydramnios treatment. So here, after finishing the treatment, I think I conclude. And thank you so much for giving me this opportunity to speak, sir. And I wish you all the best for the election. And I wish all the best to Asha madam also. We are right now currently in the season of elections only. We are just out of Lok Sabha elections and the results. And we will be entering soon into not less important at all Foxy elections. So all the best to both of you.
In fact, Swarupa, one of your slide was exactly depicting the NDA elections yesterday.
Which one?
Your slide of the incidences of the polyhydramnios, that orange and blue and everything, that was depicting the NDA scorecard yesterday.
Okay.
I thought you pasted that only. But good talk,
Thank you.
as always.
Asha madam, should I stop sharing?
Yes, ma'am. Yes, ma'am. Dr. Jyoti is here.
Any other chairperson can also conclude with remark.
No,
Dr.
no, I'm
Sonali?
here.
No,
Yes.
Dr. Sonali is here.
Yes, Ujjwala is there.
No, sir, she is in the second talk.
That's the second part. Okay.
Yes, sir. So, thank you, Dr. Swarupa. That was very comprehensive. I've taken a photo of your cartoon. So
Thank you.
I'm going to share that. It's really beautiful.
Thank you, madam.
And now we proceed to the second session, requesting for the CB of our chairpersons
Asha,
of the second.
no,
Yes, sir.
1 minute. Bharti madam had a phone call. She ended up in an emergency and she told me to prepone my lecture to second position, and she will join and she will take it on third position.
I didn't get it. Your lecture first is what you're saying?
Yes, yes.
Okay, okay,
So third lecture will be on second position.
okay. Thank you, sir. So I would like to introduce our chairpersons for the third session, Dr. Kiran Marathe, sir. Dr. Kiran Marathe, sir, practices in a village that is a Devgarh area of Sindhudurg Nagari. So practicing in a remote area for a long time. Kudos to you, sir, for that spirit of service. Sir is graduated from Krishna Institute of Medical Sciences, Karad. He's worked in pediatrics in Wadia Hospital, Sholapur. He has an MD gold medal in Gynae from Shivaji University. And with all this, he is running Rukmabai Marathe Hospital at Jamsande, Devgarh since 1996. So he's our first chairperson. Welcome, Kiran sir.
Yes, madam. Whether I am audible?
Yes, sir.
But
Yes,
not
sir.
visible.
Our second
Yes.
chairperson is Dr. Vishwas Parulekar. He's an infertility specialist with MBBS from SATE, GS Medical College, and MD from Nair Hospital. He has a diploma in reproductive medicine from Kiel, Germany. Founder and medical director of Parulekar Hospital and Center for ART and Gynec Endoscopy. Practicing endoscopy since 24 years, honorary PG teacher in NNMC Hospital at Airoli. He is also the treasurer of Navi Mumbai Obstetric Gynec Society. Welcome, Dr. Vishwas, sir. We have Dr. Rahul Vani, sir, who's an honorary consultant at Mathadi Hospital Trust, obstetrician and gynecologist at Archana Maternity. He was the president of Navi Mumbai Obstetric Gynec Society, associate medico-legal consultant, BS medico-legal consultancies. He's member of Ethics and Medico-Legal Committee, FOXY, member State Oversight Committee for HIV/AIDS, and lead assessor of Manyata Project, FOXY. Welcome, sir. Over to you, respected chairpersons, to take the program forward and introduce Patel, sir.
Hello.
Yes,
Hello.
sir. Yes, sir. Kiran,
I
sir.
think there are 18 participants in today's webinar. I think
No, sir.
everybody knows Dr.
No.
MC Patel
No.
sir very well. Still, as I have to introduce him, he is consultant obstetrician, gynecologist, and medico-legal counselor practicing in Ahmedabad. He was vice president of FOXY in 2018. He was organizing secretary AICOG in 2070. He was chairperson of Ethics and Medical Legal Committee FOXY, as well as he was honorary joint secretary and honorary secretary of State Organizing Gynecological Obstetrics Society of Gujarat, as well as he was organizing chairperson of MMCon 2018. He is honorable member of National Inspection and Monitoring Committee, PCPNDT, Government of India 2015, and he is State Supervisor Board, PCPNDT Committee, Gujarat State since in 2005 to 2009. He was president of Ahmedabad Obstetric Gynec Society from 2010 to 2011. He is honorary memorable National Managing Body and Indian Red Cross Society from 2019 to 2022. He was national president for National Medico Organization from 2016 to 2018. He was president of IMA Ahmedabad branch from 2007 to 2008, and honorary surgeon. And it was very important that he has collected 1,000 pair of eyes while working from Indian Red Cross Eye Bank. That is very, very huge work. And organizing chairperson for Vivekananda NMO conference in 2013. He was president of Lions Club of Ahmedabad in 1999-98. And I think I should introduce him as the next president of FOXY. And I wish he will be the next president of FOXY.
Thank you.
Thank you. I think everybody knows him, but as it was my duty to introduce him, I have introduced him. And I think now mic is with you, sir. Let us enlighten us with medical legal aspects of amniotic fluid embolism and what are medical legal aspects with oligo and polyhydramnios. Thank you, sir.
Thank you. Thank you for kind words.
Yes.
Let me share my screen.
Yes.
Is it seen full screen? My screen, full screen, is it seen?
Yes, yes, sir.
Yes. So straightway to the subject. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of respective society. And of course, all the delegates, all the guests, and all the faculties. Before I go to the subject, this is my humble appeal.
Shubham Karotu Kalyanam Arogyam Sukha Sampadam. Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. अथका अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So please endorse my candidature for post of President Foxy, election year 2024, considering my seniority, sincerity, dedication, and easily availability to any Foxian friends in any odd medical legal crisis. So, thank you. We are going to discuss legalities in amniotic fluid abnormality, particularly amniotic fluid embolism. Usually I start any of my talk with this question. Is it discussing yes, and if it is yes, then why? But medical legal litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. So this is real happened case with one of our Foxian friends in Ghaziabad. Patient was admitted with labor pain. She was in good health at time of admission, but no satisfactory progress. So she was advised cesarean section. Patient and relative were very reluctant to give consent. Doctor was constrained due to non-cooperation on part of patient and relative. So she insists whether you give consent to proceed with cesarean section or you can take patient to another nursing home. So ultimately consent was given, cesarean section was done, but after delivery, just after delivery of baby, patient suddenly developed cardiac arrest, cardiorespiratory arrest, and it was amniotic fluid embolism suspected. Patient was intubated and started positive pressure respiration very immediately. Patient showed signs of partial revival. LSCS was completed very quickly, and relative were informed about the sudden happening and the seriousness of condition of the patient. And then after patient was shifted in ambulance to nearby tertiary care center and with positive pressure respiration, and Dr. Monica or Manisha escorted that very patient during her transfer. In ambulance, doctor accompanying the patient, just I mentioned, patient was put on ventilatory support at tertiary care center. Patient responded, but ultimately she developed cerebral hypoxia and she went into vegetative form, and ultimately during course of treatment, she expired. So case was filed. Complaint was filed before Uttar Pradesh Medical Council and before Uttar Pradesh State Commission under CPA. So compensation demanded was 19.9 lakhs. So allegation was, we were assured about normal delivery, treated patient casually and didn't advise required investigation as per standard norm. During labor, one injection was administered, so pain was stopped, and then created a situation that it is urgently needed cesarean section, and we were compelled to give consent. These were the allegations. So during deciding this case, point in issue was whether there was any negligence or any deficiency in service while managing the patient and during performing lower segment cesarean section. So in this case, Uttar Pradesh Medical Council, because a relative of patient preferred application before Uttar Pradesh Medical Council and before National Commission of Uttar Pradesh. So as far as Medical Council's approach is concerned, they didn't find anything wrong as far as treatment part is concerned. So they didn't hold Manisha Agarwal for procedural lapses, but negligence while negligence while performing LSCS. But ethical committee was of opinion that doctors should be restricted to operate in such facility which seems not to up to mark. So they found that there were no much facility. So doctors should be restricted to operate till facility is improved. Otherwise, as far as management of patient is concerned, during cesarean section and after this amniotic fluid embolism happened, it was quite okay. There was no comment about management. Chief Medical Officer Ghaziabad should be informed that doctor will not operate in this hospital unless facilities are improved. So this instruction were given by Medical Council of UP. And in State Commission verdict was against Dr. Manisha and awarded compensation to the complainant. So she preferred appeal in National Commission because that case was in State Commission directly, because compensation demanded was 99 lakhs. And at that time, before this amendment of CPA in 2019, before it was that if compensation demanded is more than 20 lakhs, then case can directly be filed under State Commission. So in that very case, Medical Council and National Commission were, State Commission were not in favor of Dr. Manisha. So she preferred appeal in National Commission. And in that very time, in National Commission, we two medical legal experts entered into this case. And as far as this proceeding of this case in National Commission is concerned, they had very good observation and inference. In order to succeed claim in medical negligence case, three requirements need to be met. The court was very clear that there should be the three important points to be decided. One, accidental nature of misconduct on part of doctor, existence of proven damage to the patient, and it should be direct relationship. So action of doctor should be direct and proximate to cause damage to the patient. If these three parameters are decided, then only negligence can be proved against any doctor. So with these three inference, a National Commission approach in this case, doctor shall put in place all necessary measures as to the current scientific knowledge. So this was expectation from law or National Commission. Any doctor in any given situation should take all necessary measures to save life of patient as per standard medical norms. And in this case, National Commission has very specifically mentioned that doctor had performed her duty with reasonable standard and as accepted standard medical norms. And patient was appropriately referred to higher center well in time, and she escorted their very patient. And we put all these references from standard textbook of our obstetric, that is Williams. And from Williams, we put all these reference, and court consider all those reference that amniotic fluid embolism is rare but often fatal complication. Onset can neither be predicted nor prevented. Infrequent, unpredictable, the catastrophic complication causing cardiovascular collapse, and virtually impossible to predict which patients are at risk. So all these inference held by the court were very much in favor of our doctor, because court accepted that it is rare and fatal complications is very much known. Onset neither predicted nor prevented, and it is impossible to predict. So whichever references from standard textbook Williams we put before Honorable National Commission, all these arguments were accepted. Diagnosis must be based on a spectrum of clinical signs and symptoms and by exclusion of other causes. So it was mentioned in Williams Standard textbook that diagnosis of amniotic fluid embolism depends upon the exclusion of other causes, and ultimately this diagnosis comes. And amniotic fluid embolism is a syndrome, typically occurs during labor, soon after vaginal or cesarean delivery, or during second trimester dilatation and evacuation procedure. So all these things given from standard textbook of William, it was accepted by a national commission. It is virtually impossible to predict which patients are at risk of amniotic fluid embolism. Most cases of amniotic fluid embolism are associated with dismal maternal and fetal outcome regardless of quality of care rendered. This was a very important point which was taken by National Commission. In spite of quality care, result cannot be guaranteed was the inference held by the court. An early recognition of amniotic fluid embolism with prompt intervention is paramount to a successful outcome. And management is resuscitative, maintaining vital signs, and treating hemodynamic and coagulopathy disarrangement as per the case. So it is expected from any doctor in this given situation. And in this case, doctor could prove that she has managed case well in frame of this guidelines. That is resuscitative part, patient was resuscitated immediately and vitals were maintained with IV fluids and other medicines, and she was transferred immediately, and hemodynamic status was also within normal limit, and she was lucky not to end up into coagulopathy at that point of time. So all these points were taken into consideration in National Commission. One more inference held by the Commission was team approach among obstetrician, anesthesiologist, and intensivist is necessary for successful outcome. In this case, anesthesiologist was already there, and one more physician was also involved during treatment. And despite early intervention, maternal and fetal mortality remained high. So National Commission considered this point from standard textbook of William. Further, we mention all these points from William. Owing to its uncertain etiology, varying symptoms, rapid onset, and high fatality rate, amniotic fluid embolism is one of the most challenging obstetric emergency leading to cardiac arrest. Cardiac arrest is a devastating event. Despite improving resuscitative practices, mortality is high, with many survivors being left with severe neurological impairment. This was also taken into consideration by Honorable Court. Hypoxic ischemia of brain injury encompasses a heterogeneous cascade that culminates in secondary brain injury and neurological cell death. However, some do make good recovery and return to home to a meaningful quality of life. Further, it was considered long-term consequences will depend on severity of cerebral anoxia and how much irreversible damage has occurred. So residual effect with this type of situation is also known, was also taken into consideration by a court. And nature of this problem will vary from person to person depending on severity of injury and brain area affected. So all these references from Williams were considered in court in that very case, and accurately predicting those who will achieve a good neurological outcome in post-arrest comatose patient is very difficult. This was also taken into consideration. One more case was put by medical legal expert during deciding this case before National Commission. And in this very case, it was decided in Supreme Court, Achyutrao Haribhav Kovda case. And in that very case, Apex Court has an observation as follows. Skill of medical practitioner differs from doctor to doctor, and very nature of profession is such that there may be more than one course of treatment which may be advisable for treating patient. Court would indeed be slow in attributing negligence on part of doctor if he has performed his duty to best of his ability and with due care and caution. So it was very specifically mentioning that if doctor has taken utmost care to save life of patient as per standard medical norms, then it is very difficult for court also to attribute negligence on part of treating doctor. One more inference held by Supreme Court in that very case, medical opinion may differ with regard to course of action to be taken by a doctor treating patient, but as long as doctor acts in manner which is acceptable to medical profession. So whatever we do should be as per standard medical protocols and treatment part. And court finds that he has attended on patient with due care, skill and diligence, and if patient still doesn't survive or suffers permanent ailment, it would be difficult to hold doctor to be guilty or negligence. So Supreme Court was also very clear. In serious condition, doctor has to take decision. And if he has acted in a very decent manner, as far as treatment part is concerned, as per standard norms, then he cannot be held negligence if adverse result comes. And one more case was taken into consideration at the time of deciding case of Dr. Manisha, Kusum Sarma versus Batra Hospital. And this case was also decided in Supreme Court, and some references we took at the time of argument in National Commission for Dr. Manisha Agarwal. So in this case of Kusum Sarma, Apex Court, while dismissing the case, a court has very specifically mentioned that Consumer Protection Act should not be halter round the neck of doctor to make them fearful or apprehensive of taking professional decision at crucial moment to explore possibility of reviving patients hanging between life and death. So if patient is in a serious condition, hanging between life and death, doctor has to take decision and he should not be in a fear. So there should not be halter round the neck of doctor as far as Consumer Protection Act is concerned. Doctor in complicated cases have to take chance even if rate of survival is low, and doctor faced with an emergency ordinarily tries his level best to redeem the patient out of his suffering. So with these two cases decided in Supreme Court and standard Williams standard textbook references at the time of deciding this case in National Commission has inference that Dr. Manisha was qualified obstetrician and experienced one, and lower segment cesarean was performed as per standard procedure, but unfortunately patient suffered cardiac arrest due to unpredictable amniotic fluid embolism. Though immediately resuscitative steps were performed by Dr. Manisha, but patient suffered cerebral hypoxia. It was not due to negligence or deficiency while conducting cesarean section or management of amniotic fluid embolism. This was good inference held by the National Commission. So National Commission was very clear that Dr. Manisha was not at all negligent at the time of cesarean section or at the time of treating amniotic fluid embolism. State Commission has erred in law to hold it as a medical negligence. So there was comment on part of National Commission about State Commission also, that State Commission has taken this decision in wrong way, in unlawful way, and Manisha was awarded with compensation should not be there. So in this instant case, based on foregoing discussion, order of State Commission is set aside and first appeal is allowed, and consequently complaint is dismissed. So in National Commission, this case was decided in favor of Dr. Manisha Agarwal, and this case has become landmark case, landmark judgment, because after this case, in few of the cases which were faced by our Foxian friend about amniotic fluid embolism, all these Williams references, two cases decided in Supreme Court and this case in National Commission, so it has become landmark case. So with this all discussion, which are the areas for litigation as far as amniotic fluid embolism or any case is concerned. Usually on part of prosecution, this question is asked, was it preventable? And usually in other condition, we cannot say no. So if it is, but as far as amniotic fluid embolism is concerned, it is not preventable because we never know. We never can predict. So one more area, what did you do to prevent it? But in this case, it was not preventable. Why you couldn't prevent it? Cause was very evident that in that Williams textbook, it was mentioned that it cannot be predicted and it cannot be prevented. So as far as diagnosis is concerned, this was very vital point. Did you diagnose in time? Yes. This case was diagnosed well in time as far as amniotic fluid embolism is concerned. And did you manage way in which any prudent doctor would have managed? Yes, Manisha had managed that very case in a very efficient manner as far as resuscitation, transferring patient in ambulance, escorting that patient with oxygen and positive pressure oxygen rather to tertiary care center. So every amniotic fluid abnormality cases are potential threat as far as litigations are concerned, whether it is a case of polyhydramnios with any complication ending into fetal morbidity or mortality, or oligohydramnios with fetal mortality or morbidity or maternal morbidity or so. So what to do and how to prevent? So there are three conditions we have to observe. Practice foreseeability, that is anticipation, good communication and proper consent, and proper documentation, and you will be simply sailed through. As far as anticipation is concerned, court and law expect from us to anticipate certain complication or procedure or intensive care, and we should be readily available to deal with the situation. Say, for example, if it is a case of severe oligohydramnios, then we should suspect that which could be the probable complication related to that very situation, and how this case should be managed, and which kind of facility should be kept ready as far as dealing of this case is concerned. And if we have managed this case that way, it will be good enough in our favor. But proper counseling is very much important. Whether it is a case of polyhydramnios or oligohydramnios, we have to counsel patient well as far as this condition is concerned. Usually at the time of counseling, we start like this: what is the complaint? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So at the time of counseling, we have to offer all the alternative modalities of treatment to the patient with probable morbidity, probable expense in few of the condition, probable mortality, probable prognosis. All the possible complications should also be discussed, possibility of blood transfusion, all the risk involved, and need of NICU and outcome of baby should also be discussed at the time of counseling. But records are always at your rescue, so keep them up to date. What was done, nothing was neglected, given treatment fully met with the standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court, because doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. And it is very obvious: good record is good defense, poor record is poor defense, and no record is no defense. And it is my experience during my medical legal practice, we doctors' friends are very poor as far as record keeping is concerned. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many cases decided in our favor in this type of situation. There are standard guidelines or standard textbook references also in our favor. But if we do not know, then it won't be useful. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. Because in spite of all the professional and occupational hazard, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient. Pray your Almighty God before going to sleep, and keep my visiting card below your pillow. So take medical legal advice from point 1. If at all you are in a little doubt, take advice, because once you submit any document to anybody, then you cannot change it. So if at all you are in a doubt, then in apprehension that this case may go in litigation, then have a phone call to medical legal advice, go through all this document which you have prepared and have a opinion. So this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in that very given situation. So please do not hesitate and have a phone call to medical legal advisor. So God bless you. Have a litigation-free medical practice, and again seeking your blessings and support for the post of President Foxy election year 2024. I humbly appeal to vote and support in my favor. Thank you very much. With regards, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask any question, chairpersons, and time permits. Over to you, chairpersons.
Thank you, sir. Thank you for that elaborate talk, and very nicely brought out the legal points which you should put forward before the court, especially the foreseeability and the points which you need to show the court that there is no direct relationship between the complication and the Doctors Act. So these are very important legal points which should always be remembered. And as usual, the talk was very, very, very good. Thank you, sir. Thank you so much. And wish you all the best for your election, sir.
Thank you, Rahul.
Very, very, very interesting talk, MC sir.
Yes.
Thank you so much.
And this is real happened case with Manisha Agrawal from Ghaziabad.
That is why it is more interesting when you relive the whole thing.
And case was decided in favor in National Commission. Otherwise, in lower court, she lost the case and she preferred appeal. And then two of our medical legal counselor entered into this case, and they advised her advocate how to proceed, how to argue in National Commission. And we put this references of Williams and references of two cases decided, just I discussed, and case was decided in our favor. So how you represent your case in court of law with proper documentation is secret of success.
Sir, I would like to have just two questions, sir. First of all the best for your elections, MC sir, and a very nice talk. Heartiest congrats. So just two questions. Number one, obviously this patient who has suffered an amniotic fluid embolism would definitely go in for PM. Without PM, there will be no certification of the death, right? Secondly, now the State Commission had issued one statement which was overturned by National Commission. So now can the State Commission should be taken to task?
No. There
is no provision in law to...
in very recent past, there was case that should advocate be under purview of CPA.
Yeah, exactly.
And in that very discussion, case was decided in favor of advocate. And that point of time, it was good news for our medical fraternity also. Dr. Bila Trivedi and some other honorable judge in Supreme Court, they had also give their comments rather, that medical professionals should be out of purview of CPA, and we will request Chief Justice of India, Supreme Court, to consider this point, because in 1986 when CPA was enacted, medical fraternity was not under purview of CPA, and in list of service provider, medical doctors were not in that very list. But in 1995, in one case of VP Santa versus Indian Medical Association, Indian Medical Association lost that case, and then after medical fraternity were put under purview of CPA. So in that very case which was recently decided for advocate, both of the judges had given comments that that very judgment of VP Santa versus IMA should be discussed again with full bench of Supreme Court, and medical profession should be out of CPA. Let us hope it is taken by Honorable Supreme Court and some good results comes in our favor. But till then, we have to be very vigilant in our practice, and we have to counsel our patient well. We have to keep our record up to date, and we have to counsel advocate and medical legal expert well in time to face in court of law. Thank you.
Sir, all the best, sir, for
Thank you.
future elections, sir.
Thank
Dr.
you.
Nawangu here. It's nice the narration by you about that particular case. Few points has to be suggested by me, for the
Yes.
other colleagues in
Welcome.
this particular case regarding your case. One thing is that the consent has to be video consent if at all it is there. Then it might be helpful at the juncture of state commission only, because that time the things if it is a video consent, the situation might be in front of the state commission. That is another thing, that key video consent henceforward in such situations may be helpful for obstetricians. Regarding this, I have personally started video consent. It is directly informed consent to the patient and patient's relatives. It may be helpful, because this particular video consent, we are taking in a writing that we are going to take video consent and sign it on this before procedure, any procedure like cesarean section also. We are taking that particular signature. And then in such situation, we are taking, because there is a consent that you can take video consent by the relatives, it will be helpful. Another thing is that if this particular patient has been shifted to a tertiary institute for the further management, and if at all this particular patient get death on table dot, then and at this dot, what our actions to be in such scenario? Because just now Dr. Shailendra Jadhav told that why there is a MLC has to be there. If at all it is there, then PM has to be there, because it may warrant the prosecution under section 176 and 202 of IPC. So in that situation, what will be your stand in such scenario? Because it may happen, because in amniotic fluid embolism, patient may get death on table. So please suggest some points regarding this.
So, in this particular case, it was sudden cardiac arrest, cardiorespiratory arrest. She was resuscitated well, and she came out from this cardiorespiratory arrest, and she was transferred to higher institution in ambulance, escorted by Dr. Manisha herself with positive pressure oxygenation. And during course of treatment at higher center, patient expired. So 2 of her postmortem examination was on part of that very institution, because then after Manisha was out of purview of this treating that very patient. One thing, as far as your video consent comment, I would say video consent is good consent and it is accepted in court of law, but I would say it is double-edged sword. Why? Because if you miss any important point to discuss, then
go against you.
Advocate on part of prosecution may take that you didn't explain this. So I would advise better you go with video consent, but copy of written consent should be on your table, and you will see that you didn't miss any important point for discussion at the time of video consent. And for that, I would suggest to go to Foxy website. Foxy Uniform Consent are there.
Consents are elaborate.
Expert Dr. Dilip Palke from Pune, Dr. Nikhil from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. And in that very consent for cesarean section and for normal labor is also there. And in both of the consent, we have mentioned that of course it is rare, but there is possibility of amniotic fluid embolism. And in this situation, in spite of all our care and caution, result cannot be guaranteed. So if we have mentioned like this, then it becomes a good defense in our favor.
Sir, and one more thing, how much ever consent you get it signed, video consent, audio consent, paper consent, if tomorrow the opposition court, the prosecution lawyer is definitely going to say that these consents are obtained under due pressure. The
No,
discussion goes tangentially. So there is no guarantee that your video consent will save us. But as rightly said by sir, the video consent might act as a double-edged sword. Like in laparoscopy, we give the video cassette or video to the patient. That can act as a double-edged sword. So, as sir rightly said, Foxy website has beautifully elaborate and comprehensive consents. Download that, take printouts, and get it sent.
And it is available in Marathi also.
In all the languages.
So whosoever is interested can contact me. I will send both the version, English and Marathi.
Sir, you have in a lecture, you have mentioned about 5 to 6 points regarding Supreme Court's 11-point code. Actually, total 11-point code is there. In that, we can explain our, we are not at negligence on the part of that. That 11-point of code is also important to see, to plead the case actually.
We have to convince court by our record that we took utmost care of that very patient in that given situation, way in which any prudent gynecologist would have given. So if we can prove, because, and as far as I mentioned standard medical care, what is standard medical care and how it is defined or how it is decided?
All very subjective.
So court will taken into consideration standard textbook. So if it is a case of amniotic fluid embolism, how that case should be treated, it is given in our standard textbook. So did we treat that patient as per standard textbook? If yes, then it will be considered by court that we had treated patient as per standard medical norm. One more area, practice prevailing in nearby medical college hospital. If this patient was not with Manisha and this patient with a medical college hospital, how they would have managed? So this is also taken into consideration. One more area, any references of journal, practice prevailing in peer group in nearby area. In that very area with that stature of gynecology, how they manage this type of situation. If you have managed that way, it is in favor. And one more thing, expert opinion. You can request court to invite expert opinion in your favor. And if court is ready, expert opinion, a person who is senior one gynecologist, he will be given all the paper of treatment given and he will come up with expert comment that whether this case was treated as per standard norms. And if he says yes, then also you are out of problem. So there are so many ways depending the case is concerned.
True.
So I think
amicus curiae is from Foxy most of the time, sir.
Pardon?
Amicus curiae for these particular cases. Most of the time they are demanding the amicus from Foxy.
I have invited so many expert witnesses in favor of my client, and I have also been as a expert witness. So they considered as a amicus curiae when we are there as an expert witness. And the court is eager to know some important points of that very case related from us. Exactly what is the, say for example, if it is a case of PPH, then they will say what is PPH, how it occurs, can it be prevented, and how it should be managed. In this particular case, as doctor managed that case as per standard norm. So if expert witness say that yes, in this given situation, doctor has acted very promptly and he has managed that very case very efficiently, naturally court will be considering this expert witness opinion and case will be decided in favor of doctor. So
even the report, even the report of medical, the maternity death review board,
the court,
yes,
and
maternity death review board
can.
Yes.
Maternity death review board report is also considered and given weightage.
Yes.
Patel sir will agree with me.
Usually, whenever there is a case, many times Honorable Commission refer that very case to medical board to have opinion. And with their opinion from medical board, they may decide case accordingly.
That's true.
Thanks, sir. Thanks a lot.
Okay. Over to
Excuse
you,
me,
Asa.
sir. We are already at 7:30, and
Okay.
this will close at 8:30.
So,
So we have to be really fast.
yes,
I'm
conclude,
sorry I
conclude.
had to interrupt, but there's no option.
No issue.
May
At the
I
time
have
of,
Monica's
at the time of
CV,
panel,
please?
if at all any question, we will discuss.
Sure. Thank you, ma'am.
May I have Monica's CV?
Yes, ma'am.
So
Ma'am,
welcome,
don't
Dr. Monica.
Yes, ma'am.
Our
Ma'am, let's
most
not
dynamic
waste time for
national
introduction.
coordinator, most dynamic national coordinator from Public Awareness Committee, and a very, very active member, the coordinator of this whole program, website coordinator for AMOGS and the 1820, youth coordinator.
Ma'am, let's introduce the chairpersons and go
Now,
ahead with.
I request you, Dr. Monica, I welcome you and request you to introduce the chairpersons of the third session.
But before,
thank you so
before
much,
that,
ma'am.
I would like to mention only one line. In spite of her busy schedule, whenever she commits that she will take over this function, she does it. So that is good point on part of Manisha. I mean,
Thank you,
yes,
sir.
Monica. Yes.
Thank you, sir. Let me take privilege in introducing our chairpersons for today's session, Dr. Rajendra Tiwari, sir. He is the secretary of the Palghar OBGY Society, the joint secretary of IMA Maharashtra State, also the joint secretary of Association of Medical Consultants Mumbai, and a committee member of the medical legal cell of IMA Maharashtra State and FOXY. He is also the member of negligence committee for doctors at Palghar District at Civil Surgeon Office. We welcome you, sir, as a chairperson for this session. Our next chairperson, Dr. Sanjay Negudkar, sir, is the president of the Sindhudurg OBGY Society. But due to some reason, sir will not be able to join today. Our next chairperson is Dr. Ujwala Bhadraputran, madam. She is a postgraduate from VMC Solapur, my hometown. She is the director of Yash Nursing Home and Sonography Center. She is the president of the Indian Medical Association Bhiwandi for the last 5 years. She has been a working committee member and the secretary of the Thane OBGY Society, as well as an executive.
But short mein we are lacking
Yes, ma'am.
We can
We
proceed
welcome you,
ahead.
ma'am. And I would also like Dr. Rajendra Chavan, sir, who has joined late to chair this session. Ma'am, we can go ahead with the introduction of our speaker, Dr. Bharti More, ma'am.
Yes. Thank you.
Yes.
Am I supposed to introduce her now?
Yes, ma'am.
Yeah, okay. Good evening, all the dignitaries and colleagues on this platform. The topic oligonucleotide is very sensitive subject for the obstetrician. The liquor, which is the life of the fetus, has to be in proper condition, proper level. A lot of complications are with oligo, and less liquor affects outcome of the fetus. So today we'll see what's exactly oligo, why, when, how, and the management. And today, to talk this sensitive subject, we have Dr. Bharti More amongst us. My dear friend, Bharti, I'm going to introduce you. That's my privilege. She's Dr. Bharti More, and the director of she's director of Shakuntala Hospital and Fertility Hospital, Airoli. She's MBBS and MD from Mumbai and throughout first class. She's gynecologist at Srimati Radhika Bai Meghe Memorial Hospital and Sadguru Seva Mandal Trust Hospital for last 30 years. And she's honorary to Mathadi Hospital. She practices as obstetrician, gynecologist, sonologist, infertility consultant, menopause consultant, conduct free Garbha Sanskar classes since last 10 years, conduct free BMD camps for common for the last scenes for last 12 years.
I think you can stop, Ujwala.
Yeah, I have stopped, and over to you, Bharti.
I think I'll start sharing my screen. At the outset, sorry for coming late, and I had informed Dr. Monica that I was busy in the OT. Anyway, good evening, everybody, and thank you so much at the outset. All the 3-4 societies, that is the president and secretaries of Raigad, Thane, Navi Mumbai, Palghar, Sindhudurg, Nagari, and of course, thank you to the whole organizing committee, especially Dr. Asha Jain, Madam, Monica, and of course, Dr. MC Patel, sir. Thank you so much. My topic today is oligohydramnios, which is a common topic for all of the obstetricians. And indeed, it is a point to be thought over, and all of us will keep on scratching our heads. Kya karu? This is just 30 weeks and oligo hai. Abhi kaise aage jaye? Viability has to be reached. At the same time, you have to pull the POG of the gestation. So what is to be done?
Dr. Bharti, would you please make it full screen?
1 minute.
खाली आहे मॅडम, खाली असते इथे.
थांबा 1 minute.
ते कप शेप सिंबल आहे ना खाली.
Yeah. I get it.
Yeah.
Okay.
Yeah.
Thank you. So is it okay, ma'am? Asha Jain, ma'am?
Yes, please.
Yeah. So that you could see the fetus and physiology of amniotic fluid, where you can see that the x-axis is the period of gestation and the y-axis is the amniotic fluid as it goes high. You can see that after 16 weeks, 24 weeks, and 32, it goes up to 900. And then after 34 weeks, it gradually comes down. And by 40 weeks, it is almost 5 and 4 is normal. And post-datism, you have seen that it goes below that and you have to act very soon. So amniotic fluid circulation, the picture is itself self-explanatory. We can see the placenta with the amnion and the chorion levee, and how the intramembranous pathway, you can see the liquor going in and out. The baby swallows some of the fluid, the urine will put out some fluid, the intramembranous pathway, it pulls it from the placenta, and the lung fluid also comes out. So the same thing has been shown in a different picture. You can see the uterine wall with the amniotic fluid, the fetus in between, where the swallowing, urination, expiration, and swallowing of lung fluid. So of the lung fluids, that is how it is done. So amniotic fluid by 8 weeks, it's 15 ml, increases by 10 ml per week. 17 weeks, it's 250 ml, increases by 50 ml. 20 to 38 weeks, it's 750 to 1000 ml, and decreases after 34 weeks. 42 weeks, we can expect it as less than 500, which I've already told you. So what is the main function that this amniotic fluid does for the baby? It acts as a shock absorber, protects from the external trauma, protects cord from compression, and therefore, intrauterine sudden demise of the baby, the fetus rather, permits fetal movements and development of musculoskeletal system, prevents adhesions. You can see that if the liquor is less, sometimes you can have talipes equinovarus. Swallowing of amniotic fluid enhances growth and development of the GIT of the baby. Amniotic fluid maintains amniotic fluid pressure, thus reduces loss of lung liquid and therefore helps in pulmonary development. It maintains the fetal body temperature. Also, it helps the nutrition and the water supply of the baby. Also, some bacteriostatic properties it has and decreases the potential for infection. So the definition, if you see, it is not an extremely rare condition. Actually, we see it more often nowadays because you have elderly primaries and you have PIH and hypertension and all those things, glove in hand coming. So when it is, the amnia is deficient in amount, that is it's less than 200 ml a term, or sonographically it is defined as when the vertical pool of liquor is less than 2 centimeters, or that is the longest vertical pool is less than 2 centimeters in the whole of the 4 quadrants. And when the amniotic fluid index, that is you add all the 4 quadrants, taking the cord-free area, nothing comes in between, vertical level, it is less than 5 centimeters. Because I think all of us definitely do our own sonographies, and we should, all of us definitely know to diagnose what is oligohydramnios. So incidence is 0.5 to 5%. And the etiology is sometimes you see that fetal chromosome anomalies are associated with intrauterine infection, drugs like PG inhibitors or ACE inhibitors, renal agenesis that is seen in the baby, which could be because of some reasons. It could be genetic causes, where there's obstruction of the urinary tract of the fetus, therefore there's no urine formation at all. IUGR associated with placental insufficiency. Amnionodism, that's failure of secretion of the cells, that is secretion by the cells of amnion covering the placenta. Post-maturity and early rupture of fetal membranes, which also could be a cause of oligohydramnios. So causes, you can see that maternal causes, you see, there's a preeclampsia, APLA syndrome, or that's a hypertension, chronic, or there could be drugs like PG synthetase. Fetal causes, if there's IUFD, also postpartum pregnancy or IUGR, or chorionic abruption, that could be the causes. How do you diagnose? Clinically, when you see the patient, you're always, all of us are definitely seeing the patient for the frontal height. You see the centimeters from the symphysis pubis to the highest level. it has to correspond to the period of gestation after 22 weeks. So if it is smaller than that and not corresponding to the period of amenorrhea, if the mother comes with a history of reduced fetal movements, or the uterus is full of fetus and it's another anterior abdominal wall will be tight and she'll feel pain, but the os is closed. She'll feel tight, but if you do a PV, the cervix is going to be os closed. Malpresentation, most of the time, it's mostly seen. Evidence of intrauterine retardation is most of the time accompanied with it. And of course, the sonography diagnosis, where I've already spoken on. Oligohydramnios with fetal asymmetric growth, that is asymmetric IUGR, which we call as a brain sparing IUGR, could be associated with chromosomal abnormalities. So clinical diagnosis, once it's done, sometimes it could be asymptomatic, patient will not feel anything, but on examination, you will feel that there's some gadbad in this, not corresponding to the period of gestation. There could be history of leaking, where you have to see whether it's a high leak or a low leak, where the measurement changes completely, confirm the leaking, do her counts, do her CBCs, do her total count, leukocytosis, note down what is it, and you can go with the conservative management with IV antibiotics and IV fluids and IV complete bed rest with head low. Many of the times you'll be successful in pulling the pregnancy till a level of maturity is achieved, metronidazole is given, it's acted, and then you can take up the fetus, then you can take up the delivery at a place where NICU facilities are available, so that the take home baby home, you can take the baby home. That incidence is higher. You can see this preeclampsia. This is already done. I should not repeat that. Sonography, you can see that the AFI is less than 5 centimeters. What are the complications? Complications most of the time is, abortion or your preterm delivery, premature delivery, deformity due to intraamniotic adhesions, I've told you, like Talipes equinovarus, fetal pulmonary hyperplasia, cord compression, and therefore sudden IUFDs are known. High fetal mortality, Potter syndrome, malpresentations, you most of the time breach because they don't have enough of liquor for them to turn and to become vortex. And fetal distress, of course, the Apgar score is going to be low because of all these complications. A maternal complication, there will be prolonged labor due to inertia, increased operator interference, yes, because of the malpresentation, limited cesarean section rates, and increased maternal mortality and morbidity. Management depends, of course, on the etiology, gestational age, severity, fetal status, and well-being. Today, we had a patient where she came with history of pain. On examination, os was closed, and then we asked for a sonography. Sonography, it's 31 weeks period of gestation with a small meningomyelocele seen at S1 level. Just now, the patient has come with reports from Tanya ultrasound from Dr. Chaubal sir. So at 31 weeks, I don't think we can do anything. Anomaly scan done at the best of the center, it was normal. And now it is showing a small meningocele at the level of S1. So you have to just pull over the baby till the viability and deliver in a center where, if the operative intervention is needed, it will be taken in time and we can do the best for both the mother and the baby. So it depends on the etiology, the gestational age, severity, and the fetal status and the well-being, which I already told you. Targeted sonography, yes, we have already done. IUGR, IUFD ruled out. Amniocentesis, if you suspect that there is some chromosomal anomalies, especially you can do amniocentesis of the amniotic fluid, send it for FISH, and where you can come to know, and chromosomal abnormalities, of course, you can diagnose, and test for Apla syndrome if you suspect. So assessment of pregnant woman with oligohydramnios, a term you can see, 37 to 41 weeks, if you have an amniotic fluid less than 5, first of all, see whether membranes are intact or not. Review the pregnancy dating with the first ultrasound, the exact expected delivery date, and order a non-stress test. Then, depending on whether she has a PIH or diabetes or any other conditions which are associated with uteroplacental insufficiency, and do ultrasonography with a color Doppler. And then, depending on that, you take a call whether the baby has to be pulled out or you can allow the baby to grow and liquor can increase. But believe me, if there are reasons where your liquor is going to be less, that is, if there is a if there's a renal problem with the baby, or there's a meningomyelocele which we detected today, or there's an intrinsic problem, however methods you use, you give Elamine IV, you give anything, it's not going to help. That you all also know it and we know it better. So abnormalities are reviewed, and if there are any tests, yes, then you can induce labor, but no, then you have to carry on till the baby can carry on itself, especially if it achieves the period of gestation of 34 to 36 weeks, then we can give home a viable baby also. So admit the patient in the hospital, do ultrasound. Renal analysis is not present, placental function test should be performed. If there's a compression deformities or hypoplastic lung diseases, then you can give ringolactate, but I doubt if it helps more, and induce if it is placental insufficiency, because keeping the baby in is not going to help anyway either. Epidural anesthesia may be indicated to reduce the pain, but then you have to assist the second stage of labor, and you have to shorten the second stage of labor and help the mother with outlet forceps or vacuum. Continuous fetal monitoring should be done to pick up fetal hypoxia and placental insufficiency in time to take decisions. Yeah, so you can give her rest, you can give adequate hydration, monitoring with fetal biophysical profile and color Dopplers and NSTs. And once lung maturity is attained, you can do induction at a center where the care can be taken. This is the slide for amnio infusion, where it is indicated in diagnostic, prophylactic, therapeutic, decreases cord compression and dilutes the meconium and makes it less meconium, affecting the baby, and the placental insufficiency can be reduced to some extent. But there appears to be no advantage of prophylactic amnio infusion or therapeutic amnio infusion carried out when fetal heart decelerations or thick maternal staining of the LICAR has already occurred. If it is drug induced, stop the drugs. If it is PROM, if it is a low leak, you have to induce her. If it is a high leak, maybe you can pull over by monitoring the baby. PPROM, antibiotics, steroids, and induction. And if the fetus needs the surgery, as I already told you, deliver in a center where the surgical team is already informed that this baby is there in labor, is going to deliver in some time, and then you need the help of your pediatric surgeon friends. So most important thing I would say, like I've heard Dr. a little later, 5 minutes of Dr. MC Patel, sir, whatever are the complications, it is very important to counsel the parents, both the mother and the father, the Aji and the Azoba of both the sides, and you have to explain that this and this is a problem. Look, we are at the gestation at 31 weeks. If it is diagnosed, we can't deliver the baby because it is, if it is a meningomyelocele with the skin still intact, Dr. Jyoti called me and said, Bharti, I think the skin is still intact, so you can just hope for some good things coming out. So I said, wait and watch. We'll deliver her, but we'll deliver in Vadia, where I can call my friends, and if required, surgery can be done immediately. Now this is shunt relieving bladder obstruction. I think this is an intrauterine shunts which are done. I think they are done in Vadia, in Mumbai, and maybe other some centers, but I have not seen a baby as yet with the intrauterine shunt being done and taken care of. Thank you. Once again, thank you the whole team for giving me the opportunity to put a few words of experience on oligohydramnios. Thank you so much.
This one point I would like to add, Dr. Bharti, if you would permit me.
Sure.
And if the team, both in oligohydramnios and in polyhydramnios, due to various reasons, diabetic polyhydramnios and mostly oligohydramnios, there's a lot of fetal hypoxia. And fetal hypoxia can lead to fetal thrombocytosis, which can lead to fetal platelet aggregation and sudden IUFDs.
Yes.
So this we really need to keep a check on the fetal kick count.
Yeah.
Fetal kick count and the biweekly NST are the best mode to determine when we should deliver the baby. And secondly, Dr. Bharti, do you really feel that in this today's era of consumer protection and everyone filing cases against him, should we actually go in for induction of labor or advise them directly LSCS? Because I would advise direct LSCS.
Even me too. I'm with you.
Then why did you mention induction of labor?
I'm giving a talk for the students. It's a lecture. What I do in my private.
So I think it is time we should tell the student also be practical and not theoretical.
No, I know they are two different things. Writing an exam paper and doing private practice are two different things. Sir.
Writing an exam paper. Good one.
Yes. Thank you so much.
Shailendra, you
Hi, Sandy.
you can give it.
Hi, Sandhya.
A prerogative.
Bharti, you talked about daily fetal movement rate. So I would like to tell you that our beloved Sunita Tanduwadkar, she had thesis on that.
Oh.
And I was junior to her. Even after she completed her MD, in my unit, I continued the study of her same till I was there as PG student in our
And
unit.
you use the same
Until
thesis.
date,
We
yeah.
know.
I use it.
You
till
use
date.
the same thesis. मालूम है हमको.
And really, we save so many babies because of that.
Yay,
Thank you,
very
Sunita.
good. Thanks, Ujjwala.
Yes, thank you, Bharti. It was really a very good practical discussion and a lot of take-home messages with your talk. Thank you so much.
Thank you.
Thank you so much, Dr. Bharti ma'am, Dr. Ujjwala, Dr. Rajen sir, and the other Rajen sir as well. So thank you so much, ma'am. It was really crisp and you were really fast.
Thank you, ma'am. Thank you,
Thank
Dr. Asha Jain.
Thank you. It was nice. Really enjoyed and learned so much from it.
Thank you, sir.
Thank you.
Now I would like to introduce Dr. Supriya Arwari and Dr. Sandhya Saharan.
Ma'am, it's okay. We can just go ahead.
Madam, they require no introduction. They are world famous
Both
वैसे भी.
of them, they don't need introduction.
Madam, पूरा world में world famous है.
Okay,
So
okay.
I hand it over to you. I
Yes,
hand
ma'am.
it over to you, Dr. Supriya and Sandhya, both past president and secretary of Thane Obstetric Gynec Society. Welcome, welcome, dear friends. And you just have to say next, and I will take it forward, and you'll have to wind up in 35 minutes.
Okay, our time starts now, right?
Yes, ma'am.
Okay,
We'll
so
try our best. Yeah.
yeah.
So at the outset, let me thank Dr. MC sir, Asha ma'am, and Monica, who've been working so hard all these years, all the conveners, co-conveners, and my co-moderator, Dr. Sandhya Saran. I welcome all the panelists, Dr. Shamita Birbole, Dr. Rajesh Navangul, Dr. Santosh Jaibhai, Dr. Alka Gudbole, Dr. Himani Sharma, Dr. Neha Karve, and our great Dr. Shailendra Jadhav. I hope all the panelists are here on the roll. Okay, so let me start with my favorite job, and that is a shairi, because we are talking about a lot of fluid today. So I think of Dr. Ghalib's very famous shairi कि हमें तो अपनों ने लूटा, गैरों में कहाँ दम था, मेरी कश्ती वहां डूबी जहां पानी कम था. So हम लोग अभी सब पानी कम और पानी ज्यादा की बात कर रहे
गैरों में
हैं.
कहाँ दम था.
तो दिस इज
जहाँ पानी कम
ऑब्स्टेट्रिशियन गालिब का ये शेर है कि
था.
कश्ती
What
मेरी
did
वहां
Ghalib's
भी
wife
तैर
say?
रही थी.
What did
Sorry?
Ghalib's wife say? What did Ghalib's wife say? You have an answer to that also.
Yes, Ghalib's wife said, तुम तो थे ही बेवकूफ, तुम्हारे भेजने में कहाँ दम था, ऐसी जगह कश्ती लेके ही क्यों गए जहाँ पानी कम
पानी
था.
कम था.
और ऑब्स्टेट्रिशियन गालिब की लड़की ऑब्स्टेट्रिशियन है, उसने क्या कहा कि मेरी कश्ती वहां भी तैर रही थी जहां पानी कम था, मेरी कश्ती वहां भी तैर रही थी जहां पानी कम था, वो डूबी तो इसलिए क्योंकि ऑब्स्टेट्रिशियन को लिटिगेशन का गम था.
क्या बात है.
So let us just proceed with the panel. Actually, the initial part we have included much of the theory which has been beautifully covered by Swarupa and by Bharti. So I just want to ask the panelists one by one whether any particular practical tips they would like to give about the cause and the investigation in a case of oligohydramnios first and then polyhydramnios. So is Dr. Shamita there? Dr. Shamita?
I
Dr.
think
Rajesh?
we should find out who are the panelists who are there.
Shamita, you are muted.
Yeah.
Achha, Shamita is available. Rajesh is there? Dr. Rajesh Navangul? I think he's not there. Santosh?
Yes,
Santosh
ma'am,
Dikhan?
available.
Great. Okay, Rajesh is available. Santosh Jaibhai is there?
He's just messaged that he's driving. He will join.
Okay, Alka madam, have you joined? Alka Godbole madam?
No, she doesn't seem to be there.
Okay, Himani, Dr. Himani Sharma.
Yes, ma'am, I'm there.
Okay, Dr. Neha.
Yes, I'm there.
Yeah, Neha, I can see. And Shailendra, of course, is there. He's ubiquitous, always present. So, Shamita, can we start off with you? Any practical tips about, investigations that you would like to do in a case of oligohydramnios?
Yeah,
We'll have a quick round here, quick theory round. Yeah.
yeah. In case of oligohydramnios, I feel if the patient is with us for a serial sonographies, then we come to know whether it is an acute onset or it is existing before only. The one thing. And second thing, in a practically, what I found is that instead of doing amniotic fluid index in a 4-quadrant, it is generally lead to more anxiousness and more induction of labor and more LACs. I think single deepest pocket will be the more valid thing which we should do, because when we're really conducting the delivery, which is diagnosed as a oligo, there is a liker when we see during LACs or during ARM. So this is what I personally found. The second thing is that as an obstetrician, we are more worried about when we see oligohydramnios. What I feel and what is in the conference mentioned, what I could interpret is I feel fetal Doppler is more important. And if the Dopplers are good and Bishop score is low, we can really wait and follow, and we'll wait for the normal deliveries, the Bishop score to improve, and then we should not get hyper about the oligohydramnios. The second thing I found is when we are seeing for the oligohydramnios, two more important things, and we should again see the kidneys, fetal kidneys, urinary bladder thing. Second thing is a lung to be seen. And the third thing is regarding we have to strictly follow the FGR criteria, whether it is a AC below 10 percentile or serious growth potential is less. I mean, baby is big, but then if it is a 30% less than its previous growth potential, then also we should, and more importance given to the CPR ratio. I think in oligohydram, this is what we should do. And amnio infusion I did only once, but then I never thought it is worth doing it. And we are managing oligohydramnios with good color Doppler, NST, and biophysical profile. That's what I want to say. Thank you.
Okay, great. Rajesh sir, I thought, heard you giving a lot of comments on the medico-legal aspects.
Yeah.
Sir, what is your opinion? How much are we protected legally in case of oligohydramnios if we actually opt for a wait and watch or go for a vaginal delivery? Because we know that they are definitely possible that they will end up in some trouble. So what do you think should be the ideal way, so that we can give do justice to the patient, at the same time not get caught medico-legally?
First is important thing is that I'm a LLB also. That's why I'm more interested with MC Patel's lecture. That's why
Yes, sir. Yes, sir.
but medico-legal point of view, what I feel is that we have to constantly be in touch with the patient regarding the oligohydramnios, because the rapport with the obstetrician and patient is equally important. Every visit we have to counsel her properly, and this, the thing is that what is there at present scenario. So present scenario, we have to explain to the relatives as well as patient, so that they should be taken into the confidence. That is my first suggestion. That's why constantly we have to see, we have to observe. In case of oligohydramnios, to say it is oligohydramnios, then we have to see that deepest pocket, what Shamita have told just now. It is an 2 centimeter. Simultaneously, I have to suggest that to see the broadness of that also. It should be at least 2 centimeter. Below 2 centimeter diameter, that pocket we should not measure. That is one of the suggestion given. I have read in the Callan book also. So that's why I'm mentioning this particular point. So if at all it is oligohydramnios, see the CPR. Whether baby goes in less than 1 CPR in fetal hypoxemia. If fetal hypoxemia, there is no point in waiting. We have to intervene in between. That's why that is important thing to tell the patient that what is CPR actually and why the fetal hypoxemia will cause morbid condition to the fetus after delivery. That's why I suggest these particular points. So far as medical legal point is that the only thing to tell from my side is that we have to go with the care and share approach. So that is given in Foxy book. You can read it in the Foxy update volume 2. I have that, and they have written the care and share approach in such scenarios that where this particular condition goes into the dreaded condition afterwards, and we have to go ahead with the things so that we have some written documents with us so that we can provide afterwards if the allegation comes on the part of us. Because when we are taking the patient inside the operation theater, we are not taking the relatives also simultaneously inside the operation theater. So onus will be there on part of us. We doctors, the onus is on the part of us, and we have to prove that what is there we found inside, and that's why pediatrician team approach has to be there so that they can counsel the patient afterwards. This patient baby is needed neonatal care and other things simultaneously.
Dr.
Okay, thank
Rajesh,
you.
I would slightly disagree with the owner's point. Of course, there is no need to take the relatives inside the OT. Whatever your notes, whatever your findings are there, are taken as truth. So the court is not going to challenge whether you're lying in your notes. And the onus of proving the negligence is always on the patient and the prosecution lawyer.
No, that's
We
why I'm
the law will
that's why,
consider
sir,
the
I'm
doctor
telling
as
that the documentation
documentation.
on the
Yeah,
part of us
so
is important. So
documentation is the most
that I'm
important.
stressing.
Yeah,
That I'm stressing because
documentation is most important.
onus is though lies on that particular in a court,
With
but
the court,
the
the
document
onus is not on us.
helps
Onus
the
is on the
prosecutor. Okay, right. So our documentation should be
prosecution.
good and counseling should be good, in short. Okay,
Yeah.
Dr. Himani, what would be your approach in
Yes.
an early gestational
Hello? Yes,
oligohydramnios?
yes.
You know, patient who has less liker, say before 26 weeks of pregnancy, what would be your approach? And these are really tough cases, you know, especially if you get them diagnosed at 20 weeks. So what would be your approach?
Yes, so at 20 weeks, we are really worried about the chromosomal anomalies in the baby, in the fetus. So definitely, if we have to see the detailed history, if there is a previous history of any second trimester miscarriages or any chromosomal abnormalities earlier, then definitely we should go ahead with a confirmatory diagnosis of chromosomal this thing that will be amniocentesis. And for amniocentesis also, there has to be a minimum amount of liquor. So even that has to be seen, and it should be done under with expert hands. And depending on that, it has to be kept in mind that as 24 weeks is the legal limit of termination of pregnancy. So it should be done at a time which is like we have within 2 weeks, and we can tell the patient whether the fetus is normal or suffering from any congenital abnormalities. Fetal medicine specialist can be involved, which further add to our the diagnosis and management line. So these are then some abnormalities like bladder outlet obstruction, or if depends upon the type of abnormality. If it is life-threatening for the baby, then obviously the option of termination has to be given. If the abnormality is not life-threatening, like if it is treatable, small hernia or other RH incompatibility, again is one of that is with polyhydramnios. on the type of abnormality. And then IUGR has to be seen symmetric, or if there is symmetric IUGR, then again we have to see whether that is the reason for oligohydramnios in that case.
So if there is a symmetric IUGR, we would more often be dealing with an abnormal baby rather than an asymmetric IUGR,
Yes.
which is usually, in fact,
In the
there are
late trimester.
certain autoimmune disorders. We can have oligohydramnios and IUGR coming quite early. But the
Yes.
diagnostic criteria usually will be that most of these babies will be asymmetric IUGR. Okay, Dr. Neha, could you tell us about the complications, that maternal or fetal complication that we can expect in a case of oligohydramnios?
So, the most critical factor that comes into play when we are discussing oligohydramnios is most importantly the gestational age at which it has occurred. So, early and late oligohydramnios have very, very different prognosis, very, very different etiologies, and that largely determines our management plan. So if we are looking at early onset oligo, it might be a harbinger of early onset growth retardation and all the complications that come with it, with associated poor fetal prognosis. So the counseling is completely different. If we are looking at late onset, maybe something after 28 or 30 weeks, where fetus has reached viability, then we are looking at maintaining fetal well-being and prolonging period of gestation as far as possible, where the monitoring becomes very critical. We are talking about serial Dopplers. We are looking at the cerebral placental ratio, which everybody has discussed. Other things that are very helpful, which are more traditional but simpler, is something like a daily fetal kick count, which the mother can do herself. We cannot do a Doppler every few hours. So the fetal kick count, which is a very important, I can say, indicator of how well the baby is. So that is something that is helpful. Then once the baby is beyond 32 weeks, cardiotocograph is also very helpful in knowing the fetal well-being, telling us it is very sensitive for fetal hypoxia. So even beyond what a Doppler is. So that is very helpful in reassuring that, okay, even if the Likert is low, we are sure of the fetal well-being. Good variability rules out, and reactivity rules out hypoxia altogether. And speaking of complications, the questions that you asked me is complications related to, if early, then we are talking about poor fetal prognosis. And if we are looking at late onset oligohydramnios, then it depends on the degree. If it is mild or moderate, it has lesser fetal implications. If it is severe oligohydramnios, it is going to have implications on both fetal musculoskeletal development. It will have implications on pulmonary development and respiratory issues after birth, and complications during delivery. So that is the decision making whether we can proceed with a trial for normal vaginal delivery, depending on the bishops, or we are going to advise her that it is very likely that she will go into distress and we might have to think of a cesarean birth.
Right. Also, the mother is more likely to go for operative deliveries, not necessarily cesarean, but even vacuum forceps. So again, the complications related to that are going to be on the rise in the mother also. Now we have Dr. Shailendra and Dr. Santosh with us. Shailendra, about polyhydramnios, the common causes that we practically encounter, and what complications would you expect in a case of polyhydramnios?
Okay. Now polyhydramnios, where we have excess Likert, first we really need to rule out whether we are dealing with diabetes. So the most commonest complication that I can expect and I can anticipate is fetal macrosomia, a big baby that can lead to shoulder dystocia if I am attempting normal delivery. Now polyhydramnios, that can also be one of the pre-existing factor for an amniotic fluid embolism. Though rare, it can be there for the amniotic fluid embolism, because as soon as the placenta starts separating, there can be escaping of some Likert through the channels. So that's one. Then maternal injuries, two.
Very true.
These are the complications that I would be ready if I'm managing a polyhydramnios. Now, polyhydramnios taken for cesarean section directly, again, they also have a very, very small, but they have an incidence of amniotic fluid embolism. So polyhydramnios is one of the major factors to be considered when delivering.
Also, even in a cesarean, it's very difficult to deliver a polyhydramnios baby because usually baby is high floating. There's lots of
Totally
liquor,
agreed. Yeah.
and
So we
sometimes
need to drain out
they
liquor
with
first.
the liquor draining, they just go into a transverse position, and these kind of problems. Santosh, whether you will go for a vaginal trial or for a elective cesarean in case of polyhydramnios,
Vaginal trial can definitely be given with everything ready for cesarean section. And in case of cesarean, if you are confident that your decision to delivery time is very quick, then you can definitely go for trial of labor. Can do controlled ARM. Again, maybe in the OT itself, if at all you feel that if some cord comes down or if she abrupt suddenly, then you have everything ready to proceed with cesarean. But yeah, definitely cesarean in this case only for obstetric
indication.
Yeah. Okay.
One thing I would like to add to Santosh's statement is like if the patient comes in labor, active labor, then that decision becomes easy. But to induce a patient who is not in labor becomes a difficult
decision. Yes. And what a practical I have noticed is that because the baby is very high floating, very often these people don't go in labor. Instead, they go in for rupture of membranes. Not necessarily premature rupture, but rupture before onset of labor. This is also a very, real dilemma in actual practice that we face. So I think this is more or less much about how the theory we've discussed. Now let's go to the cases. I hand over to Dr. Sandhya. Asha ma'am, can you please display the slides?
One thing I want to add in this, at the time of cesarean, we can use vacuum. If there is difficulty in delivering, the vacuum helps a lot in polyhydramnios.
It's better we use.
Very true. Very true. In fact, in all floating heads, it is always good to use a vacuum. Much of the baby's morbidity is reduced by using vacuum. That's a very nice, valid point. Yeah. Asha ma'am, can you please display the slides for us?
We'll just have case 1 and then we'll go back to the gallery view. So case 1 is a primey with 36 weeks. She has an AFI of 29 centimeters. No other obstetric risk factors. Her sugars are normal. Now this patient comes to you and she hasn't followed up for a month. And now suddenly she comes with this ultrasound report and she's very worried as to how suddenly her liquor has gone up so much. What is the mode of delivery? What will happen to the baby? And what is the next line of management? So we will start with Dr. Shamita. What would you like to do when she comes to you at 36 weeks and she hasn't followed up? She had gone to the village and suddenly she's come with this report.
Yeah, man, when she comes to my place, then I'll really go through her file and I'll try to see whether her oral glucose tolerance test has been done and try to rule out the gestational diabetes, number 1. Second thing is I'll go through her
normal sugars. Her sugars are normal. That is mentioned.
Okay. Yeah. Then I'll go through, just try to rule out any congenital anomaly or anything chromosomal aneuploidy marker, whether there was anything, because then I have to take a decision regarding instrumental delivery or cesarean section. If something is wrong with the baby, there is no point going for a elective LACS or something like that. So I think the past obstetric history for a previous child and this pregnancy also is very much important for me to go through all these things. And if I found everything is normal, then I'll just reassure her. But before that, I'll just see what type of polyhydramnios she has, whether it is a mild, moderate or severe, and how much symptomatic she is. If she is not symptomatic much, then I can really wait for the normal course of the labor. But before that, I'll be really ready with her hemoglobin because they are more prone to go for a PPH and that sort of thing. So blood donors and everything should be ready for the delivery case. And then I'll reassure her, and any symptomatic, I'll wait for 38 weeks. I'll follow her 1 weekly and go with the NST and other things on.
Okay. So
one more important thing, Sandhya, this particular case is fetal neurology, fetal cardiology, and fetal kidneys. These 3 systems need to be evaluated by a senior person.
Absolutely. So we go to the next slide, Dr. Asha. This is just showing us the types of hydramnios. We generally don't see acute polyhydramnios in most of the cases. The next slide will tell you that. Mostly it is after 30 weeks that we see that, gradually it starts developing. So 29 is a little high for a patient to suddenly come with a normal sugar and having a acute polyhydramnios. So this is something which we have to keep in mind. And secondly, now what are the treatment options when we say now, whether you would like to admit this patient or you would like to, tell her that, okay, you can go home and you can come and, keep following up. So Dr. Rajesh, how would you like to counsel her? Dr. Rajesh, is he there?
Yeah, he's muted. Now he's open.
Yeah. So what is your question, ma'am?
I would like to ask you whether you will admit this patient or you will just reassure her and start a line of therapy and then ask her to come and follow up. And how would you like to manage her?
Ma'am, I will see that what are the symptoms what she is suffering from because of this acute, whether it is acute or chronic, that is we'll come to know with her previous reports. But presently, I think that this particular case looks like an acute polyhydramnios, and she may have symptoms like because this enlarged gravid uterus will have problem with the diaphragm. And the respiration problem might be she is suffering from. So she may need hospitalization as well as she may need the bed rest so far as possible. We have to see that what is the cause of her polyhydramnios. Most of the people are suggesting endomethacin, which is usually will not recommend after 32 to 34 weeks of gestation. And simultaneously, the thing is that regarding the amnio reduction, some people are suggesting that amnio reduction can be possible after admission. But we have to see that whether, because it is an invasive thing, and that's why sometimes for distress, severe distress, we can think of that also. Indomethacin is contraindicated because of sudden closure of premature closure of PDA. So that's why that will not be included in the treatment options. So all these things we have to give the supportive line of treatment at 36 weeks, so that and also simultaneously I will suggest that the beclomethasone to have an lung maturity, so that sudden onset of PROM or anything else happened, then we should be ready with her lung maturity. That's why that I need to suggest here.
Okay, so we'll stop sharing now because we'll have a bit of a discussion on this. Dr. Asha will not share it right now. And I'd like to ask if anybody has experience, has anyone used indomethacin or anybody has done amniotic fluid reduction? I mean, has anybody had experience?
Sandhya, I do use indomethacin.
Yeah.
Dr. Rajesh said indomethacin as a relative contraindication, not an absolute contraindication.
Relative. That is not an
Relative,
absolute.
yeah.
But
Secondly, the risk, no, Rajesh, the risk of spontaneous closure of PDA at 36 is there with endomethacin, but that is the same if you give crocin and ibuprofen.
Likewise,
okay. Now many times we give tablet crocin, tablet ibuprofen. No, there were two patients referred to me which sudden IUFDs. In doctors' cases, sudden IUFDs after ibuprofen tablets. So that's a relative contraindication. But tablet indomethacin, short course of 25 milligram 3 times a day or 75 milligram OD can help in decreasing the now 29, 30 AFI. Definitely, she'll have respiratory distress. So at 36 weeks, I would not rather give her indomethacin. I would rather give her steroid, give her Maxel for neuroprotection of the baby, and deliver her the next day.
Deliver. Okay.
That will be my plan of action. At 36 weeks, there is no point in waiting.
Anybody would like to give any more inputs? Dr. Himani, Dr. Neha, would you do anything differently, or you agree with this line of treatment? Anybody has had?
I will wait for at least 1 week, ma'am, in this case.
You will wait for 1 week, and you will give her steroids, and you'll wait for 1 week.
Yeah.
But anybody has tried amnio reduction, in the sense we had done it very, very long back when we were in an institution, but we had very bad results. So we had stopped doing it. Indomethacin, definitely, like Dr. Shailendra said, even I have
Practice even like we have not.
But we had a lot of, because patient is on steroids as well as indomethacin, severe gastritis. So that is one thing which you have to be very careful in counseling the patient, as it is, she is very inconvenienced because of the excess abdominal burn.
We have to explain the risk versus benefits to the patient, ma'am. That is
Yes.
important for the medical-legal point of view.
Yes, definitely. So in this now, the recommendations are that antenatal fetal surveillance is not required in isolated mild idiopathic polyhydramnios. That is grade 2C evidence. Isolated cases, spontaneous labor at term, you can induce, like he said, you can wait till 38 weeks and then you can try induction. In severe polyhydramnios, definitely no question of waiting, and it is better to deliver the patient as soon as you can. So we go to the case number 2. Now this is again to do with oligo. We'll go a bit quick because it is quite similar to what already has been discussed. But in this, the patient is on a cusp. She is a primey. She is 26 years. Okay. And she is presenting with 32 weeks of gestation with a blood pressure of 140/90. Slight pedal edema and sonography showing fetal growth restriction with AFI of 9. So now we have AFI of 9. She's 26. She's a primey. She has pedal edema. She's 32 weeks and her blood pressure is 140/90. So now who would like to take up the first? What is the line of management? What would you do at 32 weeks, which is definitely looking at hypertensive disease of pregnancy?
What would be the urine albumin?
Urine albumin, now she has pedal edema. So that we have not done it. Patient has
If the urine albumin is nil, then we can start her on anti-PIH treatment, antihypertensive, standard, admit the patient, antihypertensives, keep a control. 9 AFI is not all that bad. We can give her something called as mal masala therapy, which we all do and all give in our practice.
No, which masala you want to give? Everybody's masala is different. Choices a lot.
Well, you have that alamine and all those olivans and proteins
So
and
give
this,
us
that.
the rationale. Dr. Santosh, give us the rationale behind using all these amnio infusions.
So first of all, at 140/90, admission as such is not mandatory. Means if this
Admission
is the
not
first
mandatory,
reading,
but better to admit.
If this is first reading 140/90, if the fetal growth is okay only for a single finding of AFI 9, means a very aggressive treatment is not required for oligo, but we have to, if PIH is the cause, first of all, we have to establish that this is PIH. Secondly, the treatment of PIH. So if we have a cause for oligo, then ideally we should go ahead by treating, means we have to control her blood pressure, and home monitoring of BP can be done. And accordingly, she has to be counseled for high protein diet and no extra salt and all that we do. Now, RG prime and LMN, they have a means empirical role. We all know that the role is empirical. So what is more required is that she has to be well hydrated. So her like liquids intake should be good, at least 2 to 3 liters, either orally or if we are admitting, then intravenous. So that should be, and then depending on, means if we have to do the serial monitoring of her AFI at AFI 9, even if we tell her to keep a good means home monitoring of BP and good kick count, then we can do a weekly monitoring of AFI biophysical profile in ultrasound. If that is good, then it can be pulled till maturity, like till 36-37 weeks. So depends upon the further course of AFI.
Okay. Anyone else wants to?
I completely agree.
OPD basis hydration, actually. OPD basis hydration, if at all it is given, and simultaneously after 2 to 3 hours, if we do the sonography again, then if at all AFI looks slightly increased, that means up to 10 or 11, then I think it may be the right thing in this situation to send her home with certain monitoring of blood pressure as well as to see and keep watch on urine albumin. Probably.
Madam, here
There
in
is
the
one more thing what I also would like to suggest. This is I have practiced in my for the past 15-20 years. Administration of oxygen, regular oxygen, ward oxygen, 4 liters per minute at the rate of 4 liters per minute, and for 20 minutes 3 times a day. That has also given me very good results where I have been managed to pull on the pregnancy for good 2 to 3 weeks.
What is your opinion about amino acid infusions? Any of the panelists?
Yeah.
I have had 2 allergic reactions to amino
I have
acid
never-
injections. So
I have
I
never
don't
used it.
I don't give. Yeah, I don't give amino
I
I
have
would
never
say
used
the
it.
biggest benefit of amino acid infusion is that the patient takes good bed rest, and that probably affects the
Instead
helps with the
of
placental
IV oral
circulation.
proteins, I would recommend oral proteins, IV amino. I've had 2 bad reactions with that.
Agree.
Okay, so fine. So now this same patient comes to you, you've told her everything, she's gone home. She comes after a week. She's around 33 weeks. Now she says, I have been leaking. Sort of, she says, I'm passing like a little bit of discharge is going on, watery discharge. And you examine her, so she has a half a pad soaked, clear. It is like, absolutely, there is no blood, there is nothing. So then, and her AFI is the same. It is 9. So now what will you do?
Confirm
Now
the leak.
how will you examine her?
Confirm the leak by litmus test.
Yeah, so
paper test.
exactly.
Basic we will do the post speculum, sterile post speculum examination and try to see whether leaking is there. We can give her a pad and ask her if she's going home, if the pad is getting soaked, then please come back next day. Or we can admit her and see. And we generally, what we do is we ask them to keep the pad so that we check on the round whether it is really soaked or not. So that is the thing. Litmus and all practically we don't do it. And then
No, but litmus and pH are very much easy. It is easily available in any lab. Pick it up and quickly you get the result immediately. Alkaline आहे ते leaking है. झालं.
Yeah.
पटकन anyway it is freely available.
It is freely available.
Freely available.
Anybody has any experience with those gloves nowadays they have those AmnioSense pads. Has anybody had any experience
AmnioSense
with
pad,
that?
I have an experience of AmnioSense pad, which is good actually, but it is not a cost effective. Litmus paper test is very, very cost effective, and it is the best method. It will immediately change the color of vaginal pH if it is leaked. Because vaginal pH is acidic, and this particular amniotic fluid is alkaline, and immediately we can change and we can show that this is alkaline. Then it may early indication of high leak, and we can prevent either by strict rest, choriamnionitis prevention has to be there, or otherwise we have to see constantly the further management regarding this.
So would you
After
like
the
to do a
confirmation.
vaginal swab if you see that there is a leak? Anybody would like to do like a vaginal swab? Has anybody done fetal fibronectin, or have you examined that amniotic fluid under a microscope? Anybody has had those experiences?
Yeah, under microscope, I have checked it regarding the firm pattern and all these things actually in that. It is also easy thing actually to see that. But whatever
during our
fibronectin, fetal fibronectin levels here in periphery we cannot do because it is a remote area in a Sindhudurg district. It is a quite remote area.
Highlight on why.
सुप्रिया भिवंडी मध्ये fetal fibrosis सांगितलं तर लोक म्हणतील त्यात डिलिव्हरी होईल.
No, that is true. That is true. But you know what? When we go through the literature, there are some, like nowadays I have a lot of doctor patients who come with a leak and they've read about this, that fetal fibronectin, it has a prognostic value.
मग घ्या करून घ्या.
But if it is not seen, then what happens, they say, is at least for a week, it is reassured that the patient may not go in labor. The predictive value of the patient going in preterm labor is what is more important when you do that levels. So that is why we wanted to, know what is the rationale behind doing such an expensive.
असे गुगल पेशंट आले ना तर बेस्ट रामबाण उपाय काय आपण सुट्टीवर जायचं. And
Okay,
let our local handle it.
anybody has
But
tried
no. Will we start antibiotics for her empirically? We should.
We should.
the discussion? What I want to know, how will you what all investigations at what intervals, and basically now she is only 33 weeks, so you never know.
We should give her steroids. We should give her steroids
Maxelf,
basically for lung
Maxelf
maturity and
neuroprotection.
empirical antibiotics. But the means we have to, for investigations, usually we send CBC, CRP, and we start
Procal.
with antibiotics.
Procalcitonin is also very important inflammatory marker.
Steroid
And high
procal.
vaginal swab, if you want to send a high vaginal swab,
Yes, precisely.
that will also help the neonatologist managing the baby after delivery. That is one policy I also follow.
Yes. So basically, when this patient comes to you, so counseling is very important. I think you should keep a neonatologist in the loop, because now how many people would start Maxelf? Suppose she is now only 33 and you have started her on steroids. So which steroid will you give, and will you give Maxelf, and when will you stop it? She is not going in labor. Nothing is happening. So exactly how much Maxelf will you give, and will you stop it after 24 hours, or what will you do? Dr. Shailendra,
The steroid that I use is betamethasone 12 milligram 12 hourly, or dexamethasone 12 milligram 12 hourly, or betamethasone 24 milligram single shot. The Maxelf regime that I follow is 2 grams 6 hourly IV, only for four doses. That's 24 hours.
Okay, and then you will stop it.
And then I will stop it.
Okay. And anybody else would like to give any inputs on this,
So,
whether they would like to give Maxelf or
Maxelf we start only if we are planning for delivery. And if the fetus is less than 32 weeks, if gestational age is less than 32 weeks, fine, it's like we should give Maxelf. But beyond that, as such, for neuroprotection, the protocol is like beyond 32 weeks, we usually don't.
No, on the contrary, IAP and the neonatologist are all predicting that you can give up to 36 weeks, both steroids and Maxelf. It has a very good neuroprotection role, and for fetal pulmonary growth also, steroid up to 36 they are recommending now. In fact, there was one pediatric lecture I just attended. He said even 37 weeks I will recommend to give one shot before you deliver the baby.
Steroids are okay, but Maxelf.
So even Maxelf, yeah, and 2 grams is a very small dose. The patient will not land up in neurotoxicity even if she is just 50 kgs. In Maxelf toxicity, even if she is just 50 kgs.
So the basic recommendation is 33 weeks is what they say, till 33 weeks. But yes, our pediatricians say if she comes at 34 and she is liable to deliver, then at least give her the loading dose. And if you can buy time for even 6 hours, or you can buy time for something, give her one shot of betnesol, because there are a lot of
lot of benefit, yeah.
And a lot of people say you cannot give the entire dose of betnesol, that is 24 milligrams. So what would any of the panelists would like to discuss that, whether you will give 12 grams and you'll wait, and if she's not going in labor, then you'll withhold the second dose. What would you like to do? Anybody?
No, we complete the dose. We complete the dose. Even a single shot is okay. Double shots are okay. They all have good. They statistically proven, Sandhya, that 24 milligram single shot is equally effective as 12 milligram 12 hourly. So equally effective. So I think there is no second thought about it. Any steroid will do.
Ma'am, can I intervene?
Yes.
Yeah.
Ma'am, Government of India gives a guideline of dexamethasone 6 milligrams 6 hourly
6
for
hourly.
4 doses. That is the only thing that is allowed by Government of India, because the betnesol ampule which we are getting actually has to be a mix of betnesol 2 salts, and in India that is not available. That is why which is commercially available here is not recommended in India.
I have never heard of that.
Because what happens?
Do we have a GR on this? Because even IAP has never mentioned anything about
Dr.
that.
Gaurav sir has shared the slide, ma'am, around 1 year back regarding the same, that the Government of India recommends use of dexamethasone because the salt which is recommended is not available in India for the propionate, sir.
But we had a lot of controversy saying that dexamethasone has more propensity of intraventricular hemorrhages compared to betamethasone.
And that is why, ma'am, they give Maxelf single dose of 3 grams as a neuroprotective, not as a complete Pritchard loading, but they give 3 grams as a neuroprotective dose. No further dose is required, ma'am, if you are going to deliver the child also.
Okay.
No, but
So
this
this
is
Any
not a
any
Pritchard
any
ruling.
experience regarding Atostiban?
Sir, I have used. It
in
works
this
Yes,
case,
sir, even
wonderfully.
I have used.
It works
Atostiban has
wonderfully,
given
sir.
good results, no
Because it
doubt.
works
No doubt.
wonderfully, and a dose of this 675 milligram bolus, and afterwards we are giving 37.5 for next 24 hours, and continuously
But
we are
that is for only for uterotonics, right?
Yeah,
Uterotonic,
if
sir,
she
but
is in, if she is
Yeah,
in
uterine relaxant, uterine
yeah,
relaxants. If she's in
the
labor,
understanding here is that it is a tocolytic. The role is
tocolytic,
so that we can allow the steroid and the Maxel to act. We need at least
Dexa
24
to
hours.
act.
And for those 24 hours, we can extend using Atosiban. But
Yeah.
Atosiban, I have used because it's a very expensive drug. I have used in even smaller doses. You know, see this the loading dose and followed by 6.75 in 100 ml infusion
Okay.
over 1 hour. Only 2
mostly
shots
with that
and
also, ma'am, it
repeat. If
stops.
at all repeat after 24 hours, it give and that patient went. Now she's still ongoing and around 3-4 weeks beyond also, and she has still not gone back in preterm labor.
so
So
there's
it
one
does
word of caution.
wonders.
Yeah, it is good, but one word of caution in preterms when there is a PROM, use of tocolytics is controversial also, and also in less than 34 weeks there is an association with higher risk of chorioamnionitis. So we have to be very careful. Now the thing which is the
No,
most
so that
important,
is why these tocolytics to be used in case of a frank PROM only
yes,
to tide over those 24 hours, not
24
beyond that.
hours.
yes,
And
yes.
monitor her CBC and give her antibiotics so that she does not go into sepsis. That's for
So
sure.
one question which I want to know from all the panelists is now she's 33 weeks and within a day, within 24 hours, she's leaking frankly, like in the sense now she's like literally pouring. So would you wait or would you section her?
Now deliver section.
Deliver
You
section.
would not like to wait. If she started frankly leaking, then there is no question of waiting, right? So we have a
Yes.
common consensus. Is anybody there who would still say, no, let me at least wait till 34 weeks and I'll give her fluids and give her head low? Or if somebody does a rescue circulage or tries to put progesterone, anybody is trying that?
Further,
At 34 weeks, definitely not. Maybe a little
33.
early gestation we would consider.
So we've managed to get her till 34
I
weeks.
have done one very recently, but she is only 22 weeks. That's why I've done a circulage because she stopped leaking. And her previous baby also she has lost like this PRO. Second
So
trimester.
we had a lot of webinars and we had a lot of conferences where they were discussing this in detail, that even at 33, 34 weeks, they would give the steep head low and they would try to do a circulage. But then it has really no
with
benefit.
the better NICU facilities now, even
Yes,
patients, they are well
I think see
prepared.
today we don't have Dr. Patil from Kolhapur on the panel, but if he were to win there, he would definitely, he has done a lot of good work in the field of amnio infusion, and he has managed to even 33, 34, he would have done the salvage circulage, as you would say, and given amnio infusion and pull on till 38 weeks. He's a strong proponent.
Dr. Ajit Patil.
Ajit Patil, yeah, Dr. Ajit Patil.
So,
So he's a strong proponent.
Yes.
So I think this is all individual. What setup you are working with? What is your personal experience? So I think it's all very
And
individual.
also the population that you're catering to. If you are
Yes.
in Bhiwandi, whether everybody is concerned about I don't have the money and you don't have a big institute to support you in your area, then your hands are really tied. If
In
you
a
are in a
twins,
bigger
ma'am, one question is that
understanding patient, or there is an institute where you can admit the patient, then it really makes a difference.
Madam, one
Yes.
question for you, ma'am. If there is a twins and in the preterm, she goes in preterm labor pains, and one baby gets delivered, and now the os is closed. That bichorionic and diamniotic pregnancy, diamniotic dichorionic, and that the cord which has been this thing clamped now, and now the pains has been stopped. Is there any experience to you that patient continued for next 2 weeks and then second baby got delivered?
No, sir.
Ashi,
I don't have personal experience, but I have read
ऐकलेलं आहे.
cases.
I have
I
read
have read
cases. Yeah.
cases where they tied the cord and put it back in the vagina with septic and gave antibiotic cover, and they have taken the second twin little nearer to term. But I have never done it personally.
Rajesh sir,
Personal experience is usually within, even if the service.
Rajesh sir, असे
I'm lucky in
दंतकथे
that
ऐकले
I
होते.
have seen the patient in this government hospital Savantwadi, that one of my colleague Dr. Durbatkar have done that, and literally surprised that it went for nearly 14 to 15 days and
Arey वाह.
constantly under
क्या बात है?
observation, and that
He should present
patient
it. He
as a
should
second
really,
baby got
he
delivered.
should really
Really,
present it.
It is literally, I'm in fear of that ki definitely this baby is going to have some problem, or mother may have some problem, but luckily
कुछ नहीं हुआ.
कुछ नहीं हुआ.
जाको राकेश आई या मार सके
I
ना.
would definitely like to know the medical legal implications if you do such a thing and something happens to the mother or
Ma'am, it is a government hospital. That's why I have uttered the
Exactly.
word
But
government
you are
hospital.
under umbrella of the
Possible.
Regarding
In a
medical
government,
legal,
anything is
regarding
possible.
medical legal aspect of any case and every case, I'll tell you when does medical legal comes, when the relatives are distressed. See, one thing we have to understand as doctors, ki we are safer, they are distressed, they are really distressed. Relatives, the patient, they are distressed. तर आपण जरी पेशंटशी जरा प्रेमानं, प्रेमाचं असं म्हणत नाही, पण प्रेमानं बोललो ना, तर 99% of the medical legal cases are not there. And Dr. MC Patel also can sleep easily with the cuts.
No, that is
Hi, Kina Patel, sir.
I would
Yeah.
like to tell here, I work at Apollo Navi Mumbai. So we had a patient following up irregularly, and she was doctor herself. But sir, uska means she had an in anomaly scan, os was open, and she came for second opinion. I suggested her ki she is a primary that ki os tightening karo.
करूंगा,
But being
बरोबर है, हाँ.
doctor, they wanted to do bed rest and वो सब sustain वस्टेन लेके. तो पूरा ऐसे करके sir, she stretched till 28 weeks. She came again at 28 weeks. Whole bag of membrane was in the vagina, os open, cervical length short, 1-2 centimeter. But still she was not willing for admission. Dama, and then
Negative
at 32
consent.
at 30, sir, Dama hua and all that, 32 weeks, again same situation. Then she landed up at 37 weeks again ki now I want
I
to
thought she's
deliver.
still pregnant, 37 weeks.
37, 38 weeks, now I want to deliver, and it was a breach. Then they decided a date and कि इस दिन section करना है, and I was like कि चलो अभी तब से hang हो रहा है तो एक दिन में कुछ नहीं होने वाला. Saturday she came, I posted her for Monday. She came on Sunday, emergency with contractions, breach. So I was like very fast, and we did deliver her and everything. But baby weight 2.7 kg, all good. वही जाको रखे साइया. But
I would like to.
finally, sir, baby landed with sepsis. Baby had sepsis. Baby required. Baby had TTN. NICU में 5 दिन रखा sir, and 7 दिन का antibiotic. But they were so furious about this thing कि क्यों NICU रख रहे हैं जब इतना खींच लिया. तो they just educated patient, they denied to understand this thing, little thing.
Yeah, see, you will, Himani, you will find these sort of people across your whole life. You have to just mention your cool, त्यांना firmly, strongly, आरडाओरडा नाही, firmly, strongly सांगायचं की हे फॅक्टर्स आहेत. बस झालं आता. ठीक आहे, we are taking care in the NICU.
तो वही उन्होंने सर पीडियाट्रिशियन, हमारा तो पिंड छूट गया, लेकिन नियोनेटोलॉजिस्ट का बुरा हाल कर दिया था. तो एवरीबडी वाज लाइक कि 9 months कैसे मैनेज किया. आई वाज लाइक भगवान भरोसे बस.
Amazing case. Very
So
nice.
I have a question.
I'll tell you, Dr. Rajnish Patel here, Dr. Sandhya Saran, Dr. Supriya Arwari. These three, if really all of us, I would like to do a fellowship under these three people to learn how to speak to patients. No, I'm very serious. All just to learn how to speak to patient. And fourth one is one Dr. Prasanna Menon. She is not into our panel, but just to learn how to speak to patient. These guys are excellent counselors. Trust me. I mean, Supriya, she has the entire Bhiwandi as a khala, appa, bua, dada, tai, everyone is a relative. Sandhya speaks so beautifully. Patel sir, I've seen him speaking beautifully to the patient.
Yeah,
I would love to have a fellowship.
Hemani,
Yes, sir.
if I was in your place with the bag of membrane in the vagina and the patient is not listening to me, I would have folded my hands, told her that I'm very sorry, I cannot take care of you as an obstetrician. I suggest that you enroll yourself with some other obstetrician.
Sir,
That
the
is the
thing
best
is
way.
Sir,
That
आता
is the
Patel
best
sir,
way of.
till hard आहे आता ती how can he send all the patient ना आपण we can send
Not
our
all
patients.
that. I'm not talking about all patients. I'm talking about Atharangi patients like this. I've
आता
never
अतरंगी
heard of
येणारच sir
somebody.
आता.
I've never heard
No,
of somebody
sending
going
patient is
from
not the answer,
28,
but what Himani
Himani,
did was correct.
28 weeks
Himani,
to
was that
37 weeks.
patient's qualification
No, no.
BUMS?
What Himani did was not. I'm not saying whether Himani did was correct or
actually,
incorrect.
sir, she is a
I'm just
dentist.
telling you what I would have done.
Sir, yeah, even
If you have
I
to
thought
protect,
many
if
times.
you have to
I thought
protect
many
yourself,
times. I told them also because they came actually for second opinion at 20 weeks. So I didn't expect कि पहली बात तो वो मेरे पास आने वाली है दोबारे. And every time she was a defaulter. So I used to write on paper and I used to tell her that you go somewhere. But वो verbally हुआ है. मतलब I accept my mistake. Maybe I would have noted कि मतलब लिखा होता document क्या होता.
yeah, if
But
you are not refusing an emergency case, it is well within your rights.
Madam, I had one question.
And I'll tell you one
For
thing.
the
If
panelists.
that patient had delivered prematurely, the sky would have fallen on your head.
Madam, I had
Knowing the
a
way that they have behaved.
Yeah, but documentation तो हमने अपनी side से किया, तो we
Yeah.
were not, lacking in that.
Yeah.
Shamita, you wanted
Yeah.
to ask something?
Yeah. Suppose
Yeah.
there is a patient with a 23 weeks with severe oligo. Will you go for a termination yourself or wait for a spontaneous labor? To all panelists.
I would always wait for spontaneous labor and I'll tell the patient that her child is not going to survive right now unless she goes in for another at least 4 weeks or something like that. And I'll always wait for spontaneous labor. There's no question about terminating it just because she's got oligohydramnios.
Ma'am, severe.
Not an indication for termination.
Unless there is another indication.
Unless there is a leak.
Either a leak or bilateral renal agenesis, if you are talking about, then it is indicated, ma'am.
That does not count.
Otherwise,
malformations.
It's about malformation.
otherwise we ask her to wait till either intrauterine death or she goes into labor.
Yeah.
But even by bilateral renal agenesis, you can wait now for spontaneous labor.
No.
If it is bilateral renal agenesis, it is an indication, ma'am, for MTP.
Any abnormality, any congenital abnormality,
It will be IUFD only now within some days.
No.
Necessary,
No,
not
no,
necessary.
no.
Can see some of them deliver.
Shamita, bilateral renal agenesis can go up to term also.
It will cause anhydroamnios mostly, but yeah, it should be terminated.
It should be terminated. You should be terminated.
Echogenic lungs and this renal agenesis. Two things we can.
Unless they find out how to do a renal transplant in utero.
But you know what?
Laparoscopically, sir. Laparoscopically.
Himani,
Yes.
about the case that you described, na similar one patient I had. She didn't come in just a short cervix. She came at 32 weeks. And in Mumbai, she was advised cerclage. Okay, so she came to Bhiwandi. कि मेरे को cerclage नहीं करना है. So by the time she came to me, she was 34 weeks. At 36 weeks, even when she was not in labor, she was almost 6-7 centimeter dilated. And see now, in this case, we are happy. अरे प्राइमी है, जल्दी deliver हो जाएगी. But what happened in her case is the cervix. So this is some kind of a cervical dystocia only. After delivery, the cervix was gaping and she was pouring from the cervix. So I had to put packs inside for the bleeding to stop. 48 hours I kept the pack and then slowly removed. So
you didn't call me.
This kind of service, you invariably they will end up even with some postnatal complication,
Postnatal
especially
PPH or
non-involution of cervix.
सुप्रिया मेरे को नहीं बोला, फोन नहीं किया.
मैनेज हो गया इसके लिए. and lawyer's daughter.
सर मैडम तो इसमें वो बकरी बलून या लोअर सेगमेंट में कुछ ऐसा
see, lower segment में if you put a balloon, it's not going to stay there. In the lower segment, it is gaping.
ILEX is the only answer.
If it is a atonic PAPH, you can put a balloon inside. But in the cervix, actually speaking, other than packing, nothing is going to work.
ILEX work.
It's not going to work. It's a general. ILEX, if you have kept this, if your abdomen is open in a vaginal birth,
you will first try with pack,
and it works beautifully. Just you remember to remove the pack after 48 hours and that's it.
Actually, I have tried with this Bakri balloon and that new which one we showed that balloon. We have kept that, but even that comes out. Means
Yes,
it
in
comes out
cervix,
within
it's
6
not
hours.
going to stay. It's not going to stay in the cervix. No, cervix is
Right.
open. It's all gaping. Yeah.
Right.
Facts. Facts.
So I
Okay.
think
I
we've
think we are
had a
close
very
to
good
9 o'clock now.
discussion. Yes. We
Ma'am,
could
can
go
I
on
add
and
just
on.
one more point?
Yeah, obstetrics is a never-ending discussion, but I think we have to put a halt
Supriya,
somewhere.
you can play that video of ours.
Yes.
Ma'am,
Uh,
just one more point, ma'am. When you have a patient in preterm labor or PROM, what we generally forget is to see the oral hygiene of the patient, because most of the times dental infection is the source of infection in the body, and they'll end up with preterm labor. We have also seen quite a lot of red degeneration of fibroids landing with preterm labors, ma'am.
Not only that, many medical disorders we sometimes miss. You know, the patient comes in premature labor because she has a medical disorder which is decompensated. Never ever we should forget to re-evaluate. We are in so much of a rush to stop the preterm labor and concentrated on the baby that sometimes, you know, see subtle medical disorders we tend to neglect. And then after third day, the creatine, we had this kind of patient in Cooper who was in preterm labor, and third day, Houseman came with a creatinine report saying creat 6. And she was in preterm labor because she was going in renal failure. And you know,
My
some
God.
creatinine is the it is not something that is going to be obvious unless you investigate. Just a point to be noted that don't forget these things also. Do an
Yes,
LFT, RFT in addition to make sure
Yes.
you're not
So,
missing something.
Good
sorry
points.
to interrupt you all, but we have already extended our time, which was 8:30, and I have extended it to 5 or 10 minutes maximum. So
No, I think we
if
can
we
wind
can
up now.
conclude
Yes,
within
all
5 or
the
10
best to
minutes,
Patel
then
sir and Jain madam.
Asha
MC
ma'am,
sir, thank you so much. All the very
Thank you
best.
all
We had
for
a really great panel.
opportunity.
Thanks to all the panelists, because you all have been so wonderful, and this was exactly what me and Sandhya wanted. Something very practical instead of just giving the same theory again and again.
Right.
Practically what everybody does in practice, so that our delegates also get something, some learning points to make some practical decisions. MC sir, once again, thank you
Yes.
for
All
allowing
the
us to
best.
be on this beautiful program.
All
All
the
the
best.
best to you. You are doing great work, sir. Asha
Thank
madam, all the best to you also. Thank you for the hard work. And Monica, particularly, I know she has been at her wit's end for the last 2 weeks trying to get this entire thing together. Thank you so much, and all the very best to all of you.
thank you, ma'am. Thank you for your
Now,
appreciation.
one request to all the faculty here. The program was not relayed online for the first 70 minutes. There was some glitch with Corona. So I have shared a link which you can share again. It will have all the recording.
Wow, great. Because I've got
Thank
several
you, ma'am.
messages
Even
saying
if
they
they
could
have
not
not
join in.
been able to listen,
Yes.
they can hear the recording.
Okay, okay, ma'am. Yes. Thank you, ma'am.
Appreciate it.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Good night.
Night, ma'am.
Thank you, panelists. Thank you, Dr. Patel. And
Yes.
thank you, Monica.
Thank you,
Dr.
Rajini sir.
Thank you.
Thank you,
So
ma'am,
big
much
for
round of
making me a
applause
panelist
for
at the end of the day.
For being our
both the
academic
moderators.
partners. Thank you.
Hello.
Thank